And I can't see it's my computer clock and the bell in the background, which tells me it's 11. Good afternoon. I'm Janet Wall, CEO of the Virginia Nurses Association and the Virginia Nurses Foundation. Thanks to all of you for joining us for today's COVID-19 update. We're looking forward to the official start of our fall conference later today. After receiving requests from many of you, we added in this extra hour of content so we could provide updates on the topic that's on everyone's mind, COVID-19. Nurses can receive 1 nursing contact hour for participating in today's event and completing the brief evaluation. The Virginia Nurses Association is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. There are no conflicts of interest for any individuals in a position to control the content of this educational activity, and registered participants will receive an email with the CE survey link after this presentation. We're so pleased to again have Janine Uzel, Director of Public Health Nursing at the Virginia Department of Health, joining us, along with Joanna Pitts and Tracy White. Today, they will be sharing more with you about new information in COVID transmission, the impact on vulnerable populations, new testing options, case modeling projections for the fall, anticipated vaccines, efforts to return to in-person school, and more. Janine leads the Virginia Department of Health's Office of Public Health Nursing, and those nurses who are critical in the overall execution of health promotion, disease prevention, and community health and wellness across their entire lifespan. Janine has more than 30 years of nursing experience and has served in school health, frontline public health, health nursing, and health district and state leadership positions. With a passion for public health, Janine supports the integral role of public health nurses in improving the health and well-being of the Commonwealth citizens in an effort to make Virginia the healthiest state in the nation. Joanna Pitts, bear with me. Joanna Pitts is a graduate of Virginia Commonwealth University with a BSN and is a registered nurse. She is currently a nationally certified school nurse employed with the Virginia Department of Health as the school health nurse consultant. She enjoys community health and finding solutions for the many challenges encountered in the school setting. As the school health nurse consultant, she has been focused on working with community partners to meet the needs of our schools. Her previous career was working as an orthopedic OR PACU nurse. She worked in the operating room and recovery room, caring for patients for more than 20 years, and obtained the certified perioperative nurse credential. In her free time, she enjoys traveling, quilting, walking, and snow skiing with her family. And Tracy White is a very special guest speaker today because today is Tracy's birthday. So happy birthday, Tracy. Tracy is with the Virginia Department of Education as a school health specialist. She is a diploma graduate of Krauss Irving Memorial Hospital School of Nursing in Syracuse, New York, and completed her BSN at the University of Virginia. She later earned her MA in Instructional Strategies from George Mason University, transitioning care to community health in 1991. Tracy worked in school nurse positions at various levels and was a teacher in a career and technical center, and was also on the faculty of the Virginia Tech as a family educator. She later worked as a training director for the Virginia Leadership Education Neurodevelopmental Disabilities Program at Virginia Commonwealth University School of Education. In 2017, Tracy became the school health specialist at Department of Education, Office of Special Education and Student Services. Please join me in welcoming Janine Uzel, Joanna Pitts, and Tracy White. And thank you so much for sharing with us today.
Thank you, Janet, and welcome all. So there's some updates. As always, I open these presentations with, this is a novel pandemic, a novel pathogen, and we are still learning and trying to figure out how it works and what it does and how we can combat this and where we need to look for new things. So some information that we've sent out, we've later found not to be as effective, or I won't say true, but didn't hold up over time. So we're going to give you some new updates from what we know. We've been looking into transmission risk, and we know that airborne risk is the primary risk for transmission of this virus, but we're finding increasing evidence that the virus also can be spread by feces, breast milk, and possibly blood. There's been a lot of discussion on how long it can survive on inanimate surfaces like plastic, metal, and cardboard. We know it's at least a few hours or maybe even a few days, but remember, as time goes on, the particles sort of drift off those objects, and we're not sure how much of the virus it takes to infect you. So like we know with norovirus, it takes just a tiny amount of that virus to make you pretty sick. But we know with other viruses, it takes a much larger load to get you to that ill point. So we're still trying to figure out what the sweet spot is for inanimate objects. It's become increasingly clear that both feces and urine could become risks, particularly if particles are aerosolized. That has been found particularly true in apartment buildings and complexes in areas of China, where we feel that that was a significant disease risk for communal toilet settings. So again, that's something that we're really thinking about and looking at how we can make sure that that is not a risk in both our healthcare settings, but also when you think about it in schools, any place that you have a toilet where you can flush and it can aerosolize particles when you don't have a lid that you can put down. We're also finding that pets were a big concern early on, but we are really finding that even if pets are infected, it doesn't seem that these animals pose a significant risk of human infection. We've tried to nail down the incubation period a little bit better, and we really have found that the mean incubation period is about 4 to 5 days, but has a range of 2 to 14 days. And 90% of the people with COVID-19 infection have incubation periods of less than 12 days. There is now even stronger evidence of transmission risk when people are what we call pre-symptomatic, up to 2 days before their symptoms begin. So you're already replicating the virus, you're capable of transmitting it to others. And then we're really looking at the risk of asymptomatic transmission. What is the number, or how many people are out there walking around with the virus that never develop symptoms? Early on in the virus, we didn't have the means or methods to test everyone. So we were only testing those that were symptomatic. As we've continued to follow the initial advice of the CDC to test those contacts of people with known COVID infection, whether they're symptomatic or not, we've been able to pick up a higher number of asymptomatic individuals. And there has been some documentation that we think the number of asymptomatic carriers could be as high as 40%, who are walking around infected, able to spread the virus to others, but not have any symptoms. As we do more testing of asymptomatic individuals, those numbers could change, and it may even be higher than that. We've also seen a pretty clear picture of racial and socioeconomic disparities in population risk factors for severe COVID-19, as you can see from this slide. This data was pulled from the CDC Behavioral Risk Factor Surveillance System used nationally to determine the health of our adult population. It shows the risk factor analysis from the same survey when stratified by racial and/or ethnic group. For this question of race and ethnicity, a larger number of people, and this data comes from more than 380,000 people. As you can see, there's a large and highly significant disparity in the prevalence of COVID-19 risk factors between racial and ethnic groups, both those under 65 years of age and in the older group. And the study that we looked at when we looked at this data, we really see that it's vital that the race and ethnicity of income disparities and risk be considered when we talk about physical distancing policies. And really, we're speaking more of being physically distant yet socially connected. I think this social distancing terminology we found, people feel less connected, even though we have more video conferencing and ways that we can be virtually connected. So what do we know about COVID-19 cases and deaths among healthcare personnel? So this data was valid as of August 27th. After August 27th, it's interesting, the CDC stated they would no longer be collecting this data. But at this point in time, the cases among healthcare professionals, you can see over 144,000 and at least 661 deaths. Again, when you look at this, we have to remember that whether or not you are a healthcare status really is only available from 23% of the samples that we collected. So we don't have a true sense of how many healthcare providers were infected and never became symptomatic, how many are undercounted, what are the underestimates, and whether they actually picked up the infection in the workplace, or because we know it's so widespread in communities, did they pick up the infection when they weren't working, and the personal protective gear that we're giving them, is that effective enough in the workplace to keep them from bringing the infection home or accidentally contaminating themselves? So a couple of updates about COVID-19 in Virginia. I'd love to say that I could give you an absolutely real-time numbers. You can always look at our dashboard, but of course I have to put together these presentations before the morning of the presentation, hopefully. And so the data is a little bit off, but as of this data is accurate as of September 5th, and there were 1,199 cases. And the solid orange line represents the 7-day moving average of numbers of reporting cases. So you can see that dip that we had, and now we sort of have this uptick, and we expected that from our modeling when we started to release some of the restrictions. And we do have some concerns with schools opening up again, and particularly with institutions of higher learning. So this is the trend of deaths, and this is a great trend because it's going down. We have been working amazingly hard with our skilled nursing facilities and assisted living facilities, both to do point prevalence surveys to sort of box in those infections, identify those staff and patients that are not only symptomatic, but maybe pre-symptomatic or asymptomatic spreaders, isolate those from the general population, because those early deaths really were very hard hit in those congregate settings, and particularly nursing facilities. So you do see we've got a little dip there in July, and then we've got another bump up in August, but our numbers are looking pretty good as far as deaths, or as good as we can hope for. And the other thing is we're learning more about different treatment modalities and how to support individuals who are ill with COVID-19. When you look at the age groups, both the cases and the deaths, you see very high case numbers in that 20 to 29-year-old age group. Part of the feeling there, or just conjecture again, is that younger folks seem to think that this virus won't affect them as much as it affects older people, that they'll have more mild disease, which is, currently seems to be they're not dying, but we don't know what the long-term effects of infection with this virus are. They could be fine now. We do know, from studying viruses like polio, many young people who seem to recover fully from polio developed what we know as post-polio syndrome later in life, where it wasn't like the polio reactivated, but they were having some of the same losses of function that they initially had. When you look at infections and deaths by race and ethnicity, I think what really stands out is the high impact of cases on our Latino population in Virginia. And there's lots of conjecture about why that is. Is it, we've said perhaps they have more underlying medical conditions, perhaps access to care. Are they being infected at higher rates because they tend to work jobs that are considered essential and that they actually have to perform in person? And then the Black population has been affected as well. And again, when you go back to the table, when you look at race and ethnicity and risk factors, we know they have more underlying risk factors. But again, I think it's going to be a few years down the road and more research to know fully why different groups are affected differently. I would hate to say, I keep saying this is what we think right now, but I think we need to do some more longitudinal studies to know, yes, this is true. It's not something dietary. Is it just the risk factors, or is it something else? So more to study and learn, but do keep that on your radar, particularly when you're working with clients and knowing who may be at higher risk for severe illness. Again, our long-term care facilities have been hardest hit in this pandemic. You see that in both the case numbers and the deaths. Congregate care facilities and congregate facilities such as correctional facilities have also been hard hit. I must say the Department of Corrections and long-term care facilities are doing an amazing job of doing point prevalence surveys, isolating initially, all the people that they identify that are both ill and infected but not ill, trying to, do as much they can with hand washing, with preventing airflow between different prison pods. We do have some outbreaks in healthcare settings and educational settings, including pre-K and daycares. I know that's a concern of a lot of parents. And as you have read in the news, we are seeing outbreaks in institutions of higher learning. So we're doing a lot of contact tracing. It's very disappointing, even at this point in the pandemic. All we've got to really fight it is what I call gumshoe epidemiology, what we had in 1918 in the flu pandemic. We are doing our best. We have hired hundreds and hundreds of case investigators and contact tracers to try to get people from the point they're infected to identify their contacts. So we're going to isolate the ill and quarantine those that are not sick. We're doing a better job at developing what we call wraparound services that we have found increasingly important. It's hard for me to tell someone to quarantine and not go anywhere for 10 days if they have no groceries. So we are finding that it's been key to set up more partnerships with community agencies to provide things like groceries, to bring medicines to homes, technology. We have seen some reluctance of people as time has gone on to name any contacts for us. That's something we're fighting. And there also seems to be, I don't know if it's political or otherwise, people feel like we shouldn't be infringing on their rights to move about freely. So COVID-wise, I'm sure most of you have heard about this app, and I would encourage you to download it if you haven't. I have it on my phone. I am not a technology guru, but it uses an anonymous Bluetooth cell phone app where if you've got the app and the people that you're around have the app, and you're in each other's presence for more than 15 minutes in close contact, enough for the phone to ping off of each other, if you are positive, what we will do is when we contact you from the Virginia Department of Health, you'll be given a code to enter into your app. So it's not like random people can put in their phone, I've had a positive COVID test, and it will automatically notify everybody that you've been around. The user will receive a code, they'll download that into their phone, or upload, I guess it is, put in the code, and then the phones of the people who have been in close contact will receive a message to let them know that they have been exposed to COVID-19 and will probably be receiving a call from somebody from the health department, and then they need to go into quarantine while the ill individual isolates. So we have had a lot of calls about people thinking that this is Big Brother watching you. We're not. We're just trying to do the best we can, again, to box this in and identify people who may be exposed, both to let you know to look for symptoms, to get a test to make sure that you're not an asymptomatic spreader, and to quarantine while you're in the potential communication period. So what do we have for testing? PCR remains the gold standard, and that's that lovely NP swab that feels like it's picking your brain out. But it is still the gold standard, and it's our best test to pick up viral RNA. We use it to diagnose current or recent infections. We're trying to figure out how long the viral load may last. And even if you're not still able to spread it to others, you may have a positive test that could last for a couple of months. We're also seeing more antigen tests, which we call point of care tests. And they're to diagnose a current infection. It's a simple blood test. There are CLIA wave tests. There are a number of these on the market. What we're finding is if you get a positive result with these, it seems to be pretty indicative of having the virus. But a negative result doesn't seem to be quite as accurate. So we're still saying, you know, if you have a suspicion or if you have a negative test, follow up with a PCR. These tests are going to nursing facilities, and what we're trying to figure out is, you know, if we do the blood test and you get a positive test, do we have to follow up then with a PCR? And then the other thing that VDH is doing is we are doing a test, a study to see how many individuals show evidence of infection in the past with COVID-19 who may not have known that they were infected. And how long does that antibody persist over time? And does it offer you any degree of infection? So we have had one of our retired commissioners who has been working on this, Dave Trump. And what they're doing is trying to pull from people who are getting routine lab work done, trying to find folks of all ethnicities and age ranges to see what is the penetration of infection in the population, and can we get to herd immunity? And what the results have revealed so far is those numbers are pretty low. He's finding infection rates in the Hispanic community of up to 10% across age groups, but most of the others it's down in 2.5 to 3%. That's nowhere near where we need to get to herd immunity, if even having this disease once confers lifetime immunity. We don't know. It could be like the flu, in that you have to get your flu shot every year. Maybe now we'll all have to get our COVID shots for every year. So again, these are ongoing. I think having the point of care test will make it easier for hospitals and acute care facilities to say, yes, this individual is infected without having to wait for that PCR to come back, so that you can institute isolation procedures faster. But again, I would really caution you that the negatives are the conundrum, and you may still need to do that PCR and wait for the results. So when we look at the numbers of COVID-19 PCR test encounters, and that's what we're tracking now. So we're trying to figure out where those antigen tests will fit into our numbers. You can see the initial high peak there of infections. And what I would caution you on looking at that is, remember, early on in this pandemic, we were only testing symptomatic individuals. So you would expect a higher number of symptomatic individuals to come back as a positive result. Now we're testing asymptomatic individuals who are contacts to a positive case. So the trend that you're seeing is a little bit skewed perhaps by that. So when you look at that number, don't be lulled into a false sense of security that perhaps this virus has gone underground or fewer of us are catching it. Yes, the mitigation efforts that we have are there, but do know that that big peak also represents those folks that were symptomatic. So we had a dip, as you can see, in June on the numbers of percent positives, but we've also had some rising numbers since June. Again, we were watching very carefully after Labor Day weekend to see what happened. We were watching very carefully after Memorial Day weekend, and as we start to open schools to see where that goes. A little bit more about that point of care SARS test, SARS-CoV-2 antigen testing. You know, this is under an emergency use authorization. It's CLIA waived, so that you can do it in doctor's offices again, it's improving access to testing. It's improving how we can test in nursing homes. And we're still doing a lot of testing. So there's a number of these tests on the market, and they're all under emergency use authorizations. So do know that studies will be ongoing over the validity, the specificity, and the sensitivity of these tests over time. So you may see them come on the market. You may see them pulled off the market. You may see the way they're used changed. So, you know, you're going to be getting a lot of bulletins on these tests if you are doing labs, particularly in an ambulatory care center or an emergency room or urgent care center over time. So what do we know about testing of healthcare personnel? So basically what we're saying is if you have signs or symptoms of COVID-19, you should be tested. Asymptomatic healthcare professionals with recent or known suspected COVID-19 exposure, if it's high risk, we may exclude you from work, but that's not a given. If you're asymptomatic in special settings, such as nursing homes, again, we're doing as part of the reopening process, we may test you as well and continue to test staff and clients on a weekly basis until we can get the numbers down and make sure that we have it boxed in as we're looking at bringing in more guests and family members to visit in nursing facilities and loosening up guidelines on communal dining and letting people out of their rooms. I know there's speaking to family members in assisted living facilities who have been used to going to communal dining and having activities. I mean, they feel like they've been locked in their rooms forever, and it's very isolating and depressing. So we are saying now that a test-based strategy may allow early return to work instead of quarantine for those that are exposed. That guidance has been shifting back and forth, and I think that you will see more changes as we go into the fall and we're facing the flu season as well. But this is the guidance from the CDC as of July 17th, 2020. So what do we know about vaccines? So I've moved from the testing group to the mitigation group, and now I'm in the vaccine group. So we know that possibly by early November, and there's no firm date, so please don't hold me to that, that we may have two different vaccines. These vaccines are going to be stored at ultra low temperatures. In my career, I've never worked with a vaccine that had to be kept at -70 degrees Celsius. Vaccine A is at -70 degrees Celsius, which means it will be drop shipped to sites packed on dry ice. The dry ice will need to be replenished and handled by our staff, which is a whole new learning curve in of itself, because you can't obviously handle it with your bare hands. There are issues that it is frozen CO2, so if you leave it inside to melt, you're throwing CO2 in the room, which can cause its own issues. If you throw it in a trash can and put a lid on top of it, it can explode. You can't just dump it on your plants because it evidently kills them on contact. So this will not be like emptying your cooler of ice on your grass to water it, because you will no longer have to worry about your grass. And then this vaccine will have to be warmed. It's going to be in a multi-dose vial. It has to be mixed with an adjuvant. And then it's got to be given within a certain number of hours, all of the doses out of the multi-dose vial. Vaccine B will, and that's what we know them as now, A and B. We don't have a name. I don't have a drug insert yet for them. There'll be no on-site mixing, but it's got to still be stored at -20 Celsius. Again, both of these vaccines will have to be given 21 to 28 days apart. We expect them to be released on an emergency use authorization guideline. People will not be able to receive these interchangeably. So whatever dose you get the first time, you're going to have to get the second time. And you've got to be like right on the day, which really complicates this mission of getting this vaccine out. We do know that we will have very little vaccine when it's first released. We've developed a working group both at VDH and there is one at CDC and ACIP to determine how we should prioritize this vaccine. Should we get it to first responders and healthcare workers first? Should we get it to elderly and nursing homes first? Part of it will depend on the safety profile of these vaccines, which will be an ongoing journey for us. We will be entering any adverse effects into the vaccine adverse monitoring system known as VAERS through the CDC, and all doses will be registered in our Virginia Immunization Information Registry system to keep track of who received which vaccine when. And then we don't know how long the immunity will last for and what kind of response that we will get. So there's lots of information to come, and just to reassure you, despite some of the information that was in the news, VDH is not planning to mandate this vaccine for anyone. So what do we know about treatment options? Well, currently, as of mid-September, there are no actual drugs that are FDA approved for treating COVID-19. So what we're doing is working off of emergency use authorizations and trying to find drugs that we already have in our arsenal that we can use to treat the symptoms. So right now we do have remdesivir, which is an antiviral drug that we recommend for hospitalized patients. It is obtainable from the state pharmacy. We have found that dexamethasone and other inexpensive corticosteroids that we've had in our arsenal for years seem to dampen down the cytokine storm that you're seeing with a lot of these patients, particularly younger patients with great immune systems. We saw this in the 1918 pandemic as well. That would cause the organs to shut down in a lot of these patients. And we are using some hyperimmune plasma donated by recovered COVID-19 patients. Supportive care research that you're seeing, again, placing people on their stomachs. Does it help with supplemental oxygen? When should you put people on ventilators? When should you not? That's actually sort of an acute care realm that I haven't followed as much because my focus is more on that mitigation, vaccination, testing, and boxing in. So we are seeing in some patients that antithrombotic agents are having some effect. Again, remdesivir for hospitalized patients only, dexamethasone in mechanically ventilated patients or other corticosteroids. At this point, NIH does not recommend for or against the use of convalescent plasma. We just don't know how effective it is. If giving somebody else antibodies will be an effective treatment, those are things that we're studying right now. And except in the context of clinical trial, which is a total reversal from what we were hearing at the beginning of the pandemic, chloroquine or hydroxychloroquine with or without azithromycin, HIV protease inhibitors, interferons, pre-exposure prophylaxis, PEP, ivermectin, all those things have been tried. They haven't found to be that effective, but there are still some clinical trials going on, mostly through NIH, with these agents to see if there's any combination that would give us a better treatment modality than we now have. So what do we know about projections for the fall? So I think in previous iterations of these updates, I've talked to you a little bit about modeling. And my caution to you is that modeling is only as good as the data we put in. So what we're doing with modeling is taking a best educated guess based on what we're seeing as far as numbers, what we're seeing as far as people having more contact with each other. Again, looking at trends that we know. We looked in after Memorial Day and saw a blip upwards as people relaxed a little bit, crowded the beaches, had barbecues with families. Social events, particularly enclosed spaces, are the most dangerous, it appears. So what we are thinking now is that we will have a peak in the week ending October 18th. And again, this is just a projection. So if Labor Day really turns out to be another one of those sort of opportunities for super spreader events, again, parties, barbecues, children going back to school, college students going back to school, feeling that they're invincible, perhaps getting a lot closer to each other than we really wanted them to. People just having pandemic fatigue. I have pandemic fatigue. I would love for things to go back to whatever the new normal is going to be. Again, more churches opening up. We know that singing is an activity that can project particles through the air for long distances. Playing wind instruments, how we do that and get back to band for those schools opening in person, all of that, taking that. If we have a low impact, you can see a 10% increase in cases by the week ending October 25th. And if we have a 20% increase, we could see over 14,000 cases a week by the week ending October 25th. So time will tell, but these are our best guesstimates now of when we will start seeing peaks. And of course, this is going to coincide with the start of flu season. So this is just some information if you are wanting to see where you can find data about our modeling and our dashboards. And they're just links to our websites and other sites. So let's talk a little bit about special populations. We're hearing a lot more about multi-system inflammatory syndrome in children. And I think most of you know that we had our first pediatric death from COVID-19 in Virginia last week. And again, we're starting to see more of these cases. They look a lot like Kawasaki's disease. These, what I've got up on the screen for you are the criteria for calling it MIS-C. And at this time, if you have any cases that you suspect are multi-system inflammatory syndrome in children, we are asking you to call those in to the health department nearest to you as soon as possible once you make the diagnosis. We're really trying to figure out what are the risk factors for this, what it's looking like, and how we can identify cases sooner. When you look at race and ethnicity of these cases across the country, you can see the huge impact on the Hispanic or Latino population. Again, we can only do by conjecture of why we think that is happening. Again, you saw the disproportionate number of cases in the Hispanic or Latino populations overall. We do know they tend to live in multi-generational households, so perhaps the risk of parents spreading to the children is higher. We do know that there are higher rates of obesity in our Hispanic or Latino childhood population. We don't know if that's a risk factor. And I do know that through September 6th, we had 8 MIS-C, is what we call it, cases in Virginia, and 6 of them were reported in the Northern Virginia region. So it's not a common complication, but it can be a very serious one. And I think anybody who's a parent can agree with me that if it even affects one child, if it affects my child, it's the end of the world. It would be a very scary situation. So we're going to be talking next, and I'm going to turn this over to my school health partners about reopening Virginia's schools. I think we're getting, between reopening nursing homes to visitors and reopening schools, those are the most questions that we get at the health department. I think parents are weary, children are weary. Most of you who are nurses cannot do your work from home. You're not sending out drones delivering immunizations or IVs and then trying to tell people over a Zoom session on how to insert that in themselves. So, it's difficult to figure out how you're going to take care of those kids and keep up with their learning. And there's a lot of concern about kids that are missing out, kids that don't have the technology, families that can't afford it, families that are working off of one computer. Parents that have to go to work and can't supervise the learning because I don't know about been learning in the 6th grade or even 8th grade or probably 12th grade. So this is a whole new landscape. So Joanna and Tracy, I will turn it over to you.
Thank you so much, Janine. I'm Joanna Pitts. I'm the school nurse consultant for the Department of Health, and thank you for allowing us to speak today. Can we click to the next slide for me, please? Thanks. So when we start talking about mitigation efforts for returning to learn, I want everybody to kind of pause and think back to pre-COVID. You can do it. And actually, you might even smile, put a little smile on your face while you're thinking about it. But when we think about pre-COVID, the trend was decreasing immunization rates, and it was very concerning. It was everywhere. It was on the news. Out west, there was anti-vaxxer movements and measles outbreaks. So when March comes and COVID hits us, the CDC guidance was to prioritize vaccines for children 24 months and under. So when we forward to today, that recommendation has left us with some adverse effects in our population of 24 months and older age group. And that result was a sharp decline in the immunization rates in our school age population and our adult population. And according to the AAP, immunization rates are down about 76%, which, if you really think about that, we're talking about a global pandemic, possible outbreak, and that's kind of scary stuff. That's kind of the stuff that I like to say keeps me up at night. So we're very fortunate with our school age population in that the Virginia Department of Education encourages students to be adequately immunized for school enrollment. So this school year, the Department of Education continued to maintain that requirement that students are properly immunized, regardless of whether they were in-person learning, hybrid learning, or all virtual learning. And so as nurses, we kind of decided as a group of public health nurses, how are we going to help these families who are afraid to take their children out during this pandemic to access medical services? And when the stay-at-home orders due to COVID kind of came into play, there was a 47% decline in pediatric medical visits. So we've got these huge numbers of children that are needing access to medical care and either do not have access or are afraid to access it. So as all good nurses do, we step up. And so our Virginia school nurses decided to partner with their local health departments. And they developed a series of drive-through immunization clinics. It was an absolute brilliant idea. Efforts focused on middle school immunizations, which if we think back in our days, that's our Tdaps and our HPVs. And so the local health departments helped with providing training for the staff, that helped with providing the immunizations, the vaccinations themselves and proper storage of those. The school nurses provided staff, and they also would do pre-screening notifications for families, the administrative process of the actual vaccine. And they did all this while maintaining mitigation efforts, which are, as we all know, our three hand washing, mask wearing, and social or physical distancing. The process of the drive-through clinic was a really great, concise idea. Families pulled up in their car and they entered a series of stations. Parents are notified to stay in their car. The first station they arrived was a pre-temperature questionnaire station. If they did not have a mask, they were given one. The second station was consents and any concerns. The third station was the administration of vaccines. The fourth was a post-assessment. And the fifth, immunizations were all entered into our Virginia Department of Health immunization information system. Mitigation efforts were maintained throughout the entire process. Everyone wore PPEs, hand hygiene was performed, and it was probably the best physical distancing possible. It was more than 6 feet for the entire process and took less than 15 minutes. These clinics, like I said, were very successful. Started with the first one in the Thomas Jefferson Health District, but they have occurred in rural areas as well as city areas. The next mitigation effort that the school nurses stepped up on was developing programs for food insecure. Roughly 11 million students in the U.S. are food insecure, and a quarter of the students attending school live in households that fall below the federal poverty level, and meals are provided by the schools. So school nurses cared for their community by helping to establish programs for families in need. And while the schools were closed, many school divisions started a grab and go program for meal distribution starting about March. Now, as schools have started to reopen, and we have many students that have returned to in-person learning across the Commonwealth, schools developed plans to provide meals for students actually in their classroom or keeping them within cohorts in the school. So food allergies became a big concern for the classroom. And one way that the school nurses were able to help families and students deal with food allergies is in the classroom. Typically, there would have been a table for a student who was peanut allergy. They would have a table that that student would sit at. Well, instead, they kind of turned the tables, so to speak, and they made tables in the classroom that were peanut tables so that if students were eating peanuts, they could sit at those tables with friends who were not allergic. And yet the students that did have allergies were able to sit elsewhere in the classroom and be among their classmates. It's worked really well for the students to be able to return to in-person learning and be able to be part of their class and feel connected. We also worked with our special populations. School nurses worked very closely with the pediatricians and their students and families to assist students with maintaining and establishing individual educational plans and 504 plans. Because students are in person, the 504s and the individual education plans are still in effect, and schools are working and school nurses are working in the direction of maintaining them and establishing ones that need to be. Some of the school nurses have also helped as far as helping to provide childcare services for the essential personnel. And as far as data collection efforts, we have worked in establishing a historical perspective on COVID, kind of learning what has worked and what has not worked. And nurses around the Commonwealth have formed a team to partner with their communities to see what is working and kind of the lessons learned. And then one of the most important things the school nurses are doing are they're working with their local health departments and school administrators to form a COVID team in the school setting. The COVID team actually is a group that gets together that works on COVID preparedness in the school setting. The Virginia Department of Emergency Preparedness develops some training modules that they go over on a regular basis. The Medical Reserve Corps, our volunteers, have been unbelievably willing to help nurses with mitigation efforts within the school to maintain a safe environment and also to help with immunization efforts in the school. Our lovely partner, Tracy White, the birthday girl from the Virginia Department of Education, established a digital bulletin board with up-to-date COVID information that school nurses are able to access. It's quick, it's concise, it's a wonderful resource, it's constantly updated. And then as far as school nurses leading the way in efforts of stopping the spread, school nurses have been diligent in discussing with their communities and their schools efforts to stop the spread by wearing masks correctly and consistently, physical distancing and maintaining that 6-foot distance, hand hygiene and respiratory etiquette, cleaning and disinfecting. And they are also partnering and working as contact tracers in collaboration with the local health departments. And I'm going to turn it over to Tracy White from the Department of Education. She's going to talk about communication efforts.
Okay, thank you, Joanna. I'm glad to be here today. I want our nurse colleagues from across the state to realize that Virginia is very fortunate to have two school health specialists, one at the Virginia Department of Health and one at the Virginia Department of Education, to work together to promote the health and welfare of our children in school. I believe we're one of 2 states in the nation that support this effort. And so we are, for those parents out there and grandparents, we have been working really hard and just nursing professionals to work with our health department, our community stakeholders, our other state agencies to increase our communication efforts so that the ultimate outcome would be to provide a safe return and reopening of school. So anyway, thank you for your birthday wishes. Anyone that thinks that school nursing is just about Band-Aids and ice is very, very misled. And this is not for the faint of heart. It's a challenge during ordinary circumstances. It is increasingly a difficult situation to work in when you're working within a pandemic. I think it's quite interesting, and we're quite fortunate to have made the progress that we have made, considering schools were closed March 13th, and we've had all this downtime. A lot has happened. We've seen lots of changes. And as Janine said in her initial opening, that this is what we currently know because things are changing. It's been a challenge to see those changes. They keep changing, but it's a new virus, and so we should expect that to happen. So anyway, for those of you that want to know what, as school nurses, what we are doing when we were not in school, and to prepare for this and to make a way for your children and students across the Commonwealth to be safe, we've really had to work hard to develop relationships or enhance relationships with our local health departments and community stakeholders. As was previously mentioned, many school nurses as of March 13th were reassigned. Some remained. This is a local decision, a local school board decision in that position as an essential worker. Others were reassigned to a variety of different circumstances. We consulted on food distribution, which was really important when you think that many our kids are getting both breakfast and lunch and weekend food provided through the school setting. And so that was really fortunate. That the MRC, if you're not a member, have been great. They have been great in assistance to school nurses and preparing for not only immunization clinics, but to assist in hearing and vision screening that are just an essential part of our growth and development. and keeping our kids healthy and ready to learn in school. They have participated in 911 call centers regarding information. At the beginning, people couldn't get through to some of these localities, and so they provided a lot of information. And so through this partnership, it's like we've really been kind of joined at the hip and really seen a lot of beautiful relationships as a result of this pandemic. And I think it's only enhanced our ability to not only communicate with one another, but actually, just develop this really great relationship, because we're all connected. We all have a stake in our children. And I just wanted to note too that when I had the opportunity, and Joanna had the opportunity to host our Virginia Academy of Pediatrics recently. They've come several times to discuss the current situation to our meetings, and we've been asked to be a part of the school reopening plan and task force. So these are some unintended outcomes that have been really helpful in providing that link and that keeping in that communication kind of hub. So this is what we've been doing, and our concern, Joanna onboarded in May, and just at the health department has just been a phenomenal workhorse. And prior to that, my concern, being the only school nurse consultant for the state, was how are we going to communicate with our nurses? They're not necessarily, they may or may not be in school. How do we keep up information about how they can learn more about COVID, what's happening, how we can be, the stress, the mental health issues that are related, the family concerns, the social emotional types of concerns associated with this pandemic, how are we going to reach them? And so I started initially in March holding weekly Zoom meetings, and like today, preparing for today, many of us have become accustomed to Zoom, but as of March, it's not only about our practice, but learning how we use our technology to communicate, to our school nurses, to our interested stakeholders, and to keep them updated. And so we've done a number of professional development opportunities through our weekly Zoom meeting. We've had people from the Virginia Department of Health, American Academy of Pediatrics. We've had people from within the Department of Education meeting with nurses. And I think it's really raised awareness of what school nurses do in the school setting, and the collaboration between the different disciplines within the school, the support staff, such as the school psychologists, the speech language pathologists, the counselors, the social workers. And so it's really brought a new level of understanding and awareness to what school nurses do. And it's also provided information to our school nurse audience, which right now consists of school nurses from 132 school divisions across the state and over 2,000 public, private, and parochial schools. We've, as Joanna mentioned, we've discovered things. I'm older, and technology, I see the implications for technology. However, it's been a really stiff learning curve. So we've learned about things like Padlet, which is an online digital bulletin board, looking at Zoom, looking at WebEx, looking at some different kind of apps that are easy to use and easily translatable for just about anybody to be able to learn how to use it, and to be able to get that information disseminated to the populations that really need it. And then from a school nurse perspective, we learn by history, just like we're talking about the pandemic in 1917. We've been in touch with our European and school nurses from around the world to see how they are coping with COVID-19, and we're looking at this from an historical perspective because we know there are lessons learned, and we're just tracking and hope to be able to publish information about COVID-19 and Virginia's response in schools. We are constantly updating our information and relaying information to our school staff, our school administrators. Each school division is been required to submit a health submission plan as well as curricular content to the Department of Education. And so we've really worked, we've done a lot of writing, Joanna and I have done, when, you know, in the months that followed the closing of school and the weeks that followed the closing of school, there were so many changes and edits and waivers and revamping of what we normally do in the school setting. We've had to adapt our procedures in school. We've had to create new ways of doing things, sending kids to the clinic, sending kids home, dealing with isolation rooms, cleaning up rooms, staff, and also to address the, from a trauma-informed aspect, we know that there's been separation, there's been a change of routine, many financial concerns related to a loss of work or working at home, and just the overall emotional impact of COVID on not only our students, but our school staff as well. So just in conclusion, we're working tirelessly. We've expanded in areas, we've grown in areas such as technology use in order to keep our kids safe, our school staff safe and informed, and we'll continue to do so. So I want to thank you for your time today.
And this is our contact information, and I believe Virginia Nurses Association is sending out these slides to you, so you will have these contact information if you need them. So I think, you know, in summary, COVID isn't going away anytime soon. It's going to continue to be with us. You're hearing a lot about the twindemic that we're worried about for the fall, which is influenza and COVID at the same time. We know that flu season for hospitals is already a tough time. I would challenge you to think that we're actually in a triple-demic. What we are seeing is the emotional toll of this pandemic. Information came out this week, and perhaps we'll be sharing some with you on a later update about the spike in overdose visits to emergency departments. The uptick of opioid use disorder relapses that are very concerning. We're working very hard to get naloxone back out into the community. I will remind you that Virginia remains a hepatitis A outbreak state. That did not go away during this pandemic, but we've had to scale back our mass vaccination campaigns. We're very concerned about both elder abuse and child abuse. We know that when schools reopen, we get those higher numbers of CPS calls. When we make home visits to screen individuals for Medicaid long-term services and supports, we get those APS calls. With DSSs not going out on home visits, we're very concerned. So I think you just need to be very aware as a nurse, because we're used to looking at someone from a holistic view, that there are other issues from this pandemic than just COVID-19. The stress levels and the unintended consequences, I believe, will be felt for years. So we are still learning more about this virus and its transmission. I think you'll hear a lot more about fecal aerosolization and urine aerosolization and the role and spread. And some interesting on watching increased numbers by just checking for viral loads in sewer systems, which I'm glad is not my job, but I'm glad somebody out there is doing that. We think a vaccine that is safe and effective is coming, but I can't promise you how soon that will be there, how easy it will be to get into people's hands. Just the training alone on the mixing, the storage, the disposal of the dry ice, how we track individuals. I mean, that's a huge load. I mean, that's pretty much consuming most of my day. No one can be an expert in every aspect of this virus. We're going to have it spreading in Virginia, perhaps over the next 2 years. I think that just needs to be a realistic outlook for everyone, and how we cope will be the new normal. It's not going to be back to the world it was. It could be a better place. So again, observation, communicating with your local health department, and obtaining information from trusted sources, and encouraging all of your patients to obtain information from trusted sources is so critical. We at the health department will tell you, and we don't know. Or, yes, last week this was our advice, but this week this is our advice based on this is what we know. So thank you. I did include some slides with some health department locators. If you're not sure where your local health department is, that's where you need to report COVID cases, any missed cases as well. This is our call center. And again, our official coronavirus page where you can go for information. These are some more places that you can go for information. And thank you. And I will stop sharing my screen. And I'm not sure if we have time for any questions from me.
I think yes, this is Janet. I think we have time for a few questions. Thank you so much for the wealth of information. I think we can go for at least 5 more minutes, and let me switch back to my document that tells me the questions, which did not switch back. Well, that's lovely. Okay, let me go to my Zoom document. Here we go. Okay, so just a comment from one individual as a psych nurse practitioner. This is from Eve Poteet. I can tell you that depression and anxiety in the adolescent and young adult community is skyrocketing. I work in military and civilian community. And yes, we're very aware of that, and it's disheartening. We are doing some initiatives through our foundation to try to address this to some extent, and I know many other organizations are working on this as well. So since I lost my other document, let me just scroll up and see if I can see the questions. Bear with me. Melody Dickerson said, we are told that the virus spreads within a 10-day window. Wouldn't we already be seeing the impact of a super spreader from Labor Day if that had happened?
Yes and no. So remember, a number of those individuals may be asymptomatic. Mm-hmm. So it's going to be the first group that gets the virus. Some will be sick, and you saw that little bit of an uptick, but it takes a little while for it to snowball. So if we think that 40% may be asymptomatic, then that 40% is still spreading. And so it's going to have to go what we call a couple of generations of spread before you get to see those big ticks. And then remember, if every one of those people that was infected, if 40% of those are asymptomatic and now they're spreading, it's going to take longer till you see the peak of that curve. And that's why we're really anticipating that possibly that will be into October. So it takes a little while for it to get going.
Thank you. Another question, how are risk factors, education being communicated to the Latino and Black populations?
So we have tried to partner with organizations across Virginia and with our community health workers, who are generally individuals that are trusted in their own community. We've been trying to put out education on both Facebook, our social media sites. You may have seen some of our billboards that we have up in both English and Spanish. You know, we're working in a very politically charged environment, and people who are not here with the right papers, who are not documented, do have fears. We're doing the same with the Black community. You know, traditionally, we have partnered very heavily with the faith-based community. And that has been somewhat of a challenge as churches have moved to Zoom platforms as well. And you're not able to have that, quote, one-on-one interaction. We are making efforts. Our health equity working group was formed by the governor to address some of these issues and to pull in trusted members of the community so that we can be informed by those folks how best to reach their communities. And again, we call it WEG, but it's the Health Equity Working Group. And that was convened by the governor to address some of these issues and to get the word out to communities and figure out the best way to reach for testing, for linkages to care, for ancillary services, and eventually for vaccines.
Thank you. Another question, does VDH have a way to monitor and document how many people are using the app? And there was also some interest in how many people are currently using the COVID-Wise app now.
So we can measure downloads. So once you download it, it's turned on, and my little app gives me a report once a week, and I'm happy to say it's been saying, hey, good news, you haven't had any pings from anybody positive. What we're trying to figure out is what the uptake is for people willing to enter the code into the app when you do have a positive result. And how we can increase the use of the app across, younger folks are generally more app friendly, but how we can increase the use of that across all populations. But we can measure downloads, and I haven't looked to see what the download number is. So I would be remiss if I just threw one out there because I can't remember. I want to say it's 50,000, but I'm not 100% sure. I haven't looked that up.
Oh, that would be fabulous. And then I'm going to take one more question, but I also wanted to mention to everyone, because we talked a little bit about the possibility of a twindemic with the flu and COVID this fall. And I wanted to mention that VNA, the Virginia Nurses Association, is one of several nurses associations throughout the country who are working on a partnership that was formed between the American Nurses Association and Sanofi Pasteur, which is the business, it's the vaccine component of Sanofi. So they do all of the vaccinations. And we have a partnership on a public relations campaign and some community outreach to raise awareness about the need for the flu vaccine and concerns regarding a twindemic. So you'll be seeing more about that, I think, in the weeks to come. The last question we'll ask, what measures should be implemented for the communal bathrooms? No lids and are not cleaned between users. Do the seat covers offer any protection?
Again, what we think today, which may change tomorrow, is it's the aerosolization of the particles. And so seat covers, plastic seat covers, I'm not sure would really provide you what you're looking for. It's when you flush and everything is aerosolized and you're breathing that. I'm just picturing myself like flushing and holding my breath and running back out. So actually wearing your mask, that would be one of my recommendations to help prevent you from breathing in any particles. It's a unique thing that I have thought about for years, particularly during norovirus outbreaks, and whether that has, the way for flu as well, but as interesting as it sounds, it may be one of our prevention measures to do a campaign of close the lid or close before you flush, or we may find out down the road that we thought that was a great strategy, but turns out not to be so much. So, it's just what we know today from what we're seeing from the spread in China. We think that was and what we know also from SARS initially, that was a way we think it was spreading in apartment buildings.
Great. Well, thank you very much. And I think you're right. Let's take it back to the importance of the mask.
Absolutely.
So I really appreciate, I know we went over our originally allotted hour of time, but this is such important information that we really didn't want to cut it short. So thank you to everyone who stayed on the line, and also, of course, to our presenters who gave us that extra almost 15 minutes. We'd like to now invite you to visit with our exhibitors before the official start of our conference today at 1 p.m. To access our virtual exhibit hall, simply follow the link on our conference landing page, which is tinyurl.com/2020 VNAF, as in Frank, C. You'll have a chance to win an Amazon gift card by participating in our virtual exhibit hall scavenger hunt. And also just a reminder that all of the information you need for today can be found in your conference email or at tinyurl.com//2020 VNAFC. And I think that's it for today. Again, thank you so much for your presentations.
Thank you.
Okay. And
Yes.
we will see many of you very soon as we go into the fall conference. Thank you.
Thank you.
Thank you.
Good morning. Oops, afternoon. I'm Janet Wall. I'm the CEO of the Virginia Nurses Association and the Virginia Nurses Foundation. Great to see you all here today. Welcome to our 2020 Fall Conference, Ending Incivility, Bullying, and Workplace Violence. Thank you to all of you, our attendees, our speakers, our exhibitors, and our sponsors for being incredibly flexible as we shifted to a virtual conference amidst the COVID pandemic. We know it's crucial that nurses are able to stay healthy while being on the front lines of care, and so happy to have the opportunity to present this conference to you virtually. We wanted to extend a special thanks to those of you who have been on the front lines of the COVID-19 pandemic. You are always in our thoughts, and we are so very appreciative as well as in awe of everything you're doing. Today, we're going to be discussing nursing incivility, bullying, and workplace violence, and how to proactively address these issues and work toward ending them in all practice settings. These issues take a toll on nursing morale, retention, and patient outcomes, and have been part of the healthcare conversation for far too long. Let's explore real-time strategies that both you and your employer can take to stop the trend. This year, we slashed our event prices as a pay-it-forward gesture in thanks for the tremendous support we have always received from nurses and their employers. So a huge thank you from us for your continued support of the association. Before we get started, I have a few important thank yous and announcements. First, a huge thank you to all our Fall Conference Planning Committee members. It's been a real joy to work with them and to create what we believe will be a rewarding experience and excellent investment of your time. Thank you to Nursing Education Commissioner Kathy Cox, Linda Shepard, Deborah Kyle, Kimberly Brown, Nina Beeman, Jennifer Shepard, Melissa Early, and Terrace Kennedy. We are so grateful to all our sponsors. Thank you to our keynote sponsor, the Virginia Council of Nurse Practitioners and the Virginia Hospital and Healthcare Association. Our exhibit hall sponsor, Virginia Relay, and to our break sponsors, Virginia Relay and Novant Health UVA Health System. Thank you to each of our 21 exhibitors. I think this might be the most exhibitors we've ever had. During our networking breaks, be sure to visit our virtual exhibit hall. You can find our virtual exhibit hall by going to our Fall Conference virtual landing page link provided to you in the YouTube event description or in the email sent to you for today's program, or by visiting our event landing page at tinyurl.com/2020 VNAFC. Many of our exhibitors will also be offering live virtual sessions during breaks for you to join, and you can find links to these in our virtual exhibit hall. If you experience technical difficulties today, make sure your device is connected to the internet, that it's a strong internet connection, and that your volume is turned on. You can also try a different browser, and make sure you are frequently checking your YouTube screen for the word live in the top left corner. If you aren't live, you're not watching in real time. We also recognize that sometimes there are some technical issues and that if you refresh them. If you're still experiencing issues, visit our VNA Zoom room for live assistance. You can find the link in your conference email or on our conference landing page. If you cannot access Zoom, email your issue to Jackie Jester at jjester@virginianurses.com or text our helpline at 804-349-5578, and we'll do our very best to assist you. If you get disconnected or need to step away, don't worry. You can rejoin us in progress. We are recording the event, and as an attendee, you will also have access to the entire recording after the conference. Nursing contact hours will be awarded commensurate with your participation upon the completion of an evaluation. The evaluation will be mailed to you within 1 week following the conference, so be sure to check the email you used to register. At this time, I'd like to draw your attention to VNA's Civility Pledge. In tandem with the content that we are showcasing today, a team of nurse leaders across the Commonwealth created this pledge to help bring an end to incivility, bullying, and workplace violence. We know that this is just the first step into creating a more civil workplace, and we hope that you will use it in conjunction with taking such action after our conference ends. The online form can be found by going to the link on the slide, www.tinyurl.com/VNA Civility Pledge. We ask that you take 5 minutes to fill out this form as a promise to work with others to foster the perfect nursing environment. Signers will receive a temporary electronic certificate immediately upon submission, and a hard copy will be mailed within the following weeks. Please feel free to share pictures of your hard copy certificates and your next steps with us on social media so we can spread the word. And again, please know that we know that this is just one prong of a multi-pronged approach that is, or a many-pronged approach that is necessary to address these issues. And now back to our regularly scheduled programming. Throughout today's program, we will utilize the chat box in your YouTube live stream feed to allow you to ask questions and respond to presenters during the program. We want everyone to get comfortable using the chat box. So please find your chat box now and let us know what is the one thing you hope to learn from today's program. Now we'll see how adept I am at switching to that so I can see what your responses are. Linda Smith says, I will introduce this at my workplace. Others? All right. I know you'll have lots of ideas before this is all over, so we will ask you again a little bit later. Thank you for sharing. And remember that the chat box is available to you to engage with our presenters throughout the program today. I'd like to now introduce Linda Shepard, VNA President and Chief Nursing Officer with Johnston Memorial Hospital, a Ballad Health facility in Abingdon, Virginia. Linda?
Good morning, everyone. I hope you're all ready for a great event. We've got a fantastic lineup of speakers who will be delving into recognizing, addressing, and preventing workplace bullying, incivility, and violence among nurses in healthcare settings. Our keynote presentation today focuses on practical, real-world solutions that empower healthcare employees to recognize disruptive behaviors, develop the skills needed to confront and eliminate those behaviors, and transform their unit into a nurturing, supportive, and professional environment. And now it's my pleasure to welcome our keynote sponsor, the Virginia Council of Nurse Practitioners, to speak more about their organization and introduce our keynote speaker, Diane Salter, right after this brief video.
Welcome, VNA Fall Conference attendees. My name is Becky Compton, and I am the president of the Virginia Council of Nurse Practitioners. Thank you for taking the time today to connect with nurses across the state in this virtual format, to learn best practices, new techniques, and focus on the theme, Ending Incivility, Bullying, and Workplace Violence. I would like to thank the VNA for this opportunity to address the audience and send a special thank you to you as an attendee for joining nurses across the state of Virginia at the VNA Fall Conference. Before I introduce the keynote speaker, I would like to briefly share some information about the Virginia Council of Nurse Practitioners. I am in my first term as president of the VCNP and have had the pleasure of holding a variety of leadership positions in our organization for nearly a decade. I'm a doctoral prepared family nurse practitioner working at the UVA Family Medicine Clinic in Charlottesville, Virginia. The VCNP has a lot of exciting things going on, including various legislative receptions happening around our state. Please visit our virtual exhibit booth for more information about the Virginia Council of Nurse Practitioners. And there we've included a video about the association, social media links, career counseling for those who may be interested in becoming a nurse practitioner, and much more. Now I'm honored to introduce your keynote speaker, Diane Salter. Diane Salter has been a nurse for 20 years and holds professional certifications in peri-anesthesia nursing and as a nurse executive. Although most of her experience is in the surgical environment, she spent 2 years in the emergency department as a sexual assault forensic nurse examiner. Diane served as the nurse manager of the post-anesthesia care unit and short stay unit at WellSpan Health York Hospital in York, Pennsylvania. There she served for about 10 years and is currently the Director of Surgical Services for WellSpan Health Ephrata Community Hospital in Ephrata, Pennsylvania. Diane has always been passionate about working with her staff to create healthy and caring work environments. And this is one of the main motivators for her in joining Dr. Renee Thompson's Healthy Workforce Institute. On the topics of bullying and incivility, Diane has presented at Sigma Theta Tau's International Conference on Creating Healthy Work Environments, Johns Hopkins Advanced Nursing Leadership Academy, the Student Nurses Association of Pennsylvania State Conference, and the Pennsylvania Association of Peri-Anesthesia Nurses State Conference. Currently, she serves on the American Nurses Association in Nurse Abuse Professional Issues Panel Advisory Committee. In her own healthcare system, Diane has conducted workshops on bullying and incivility for more than 2,000 staff and continues to be the subject expert for her organization. At her former hospital in York, she served on both the hospital-wide Workplace Violence Committee and the Employee Engagement Committee, specifically addressing the topic of abusive behavior. Please welcome Diane Salter.
Thank you very much to the Virginia Nurses Association for having me here today. These are definitely challenging times. This is my first experience, and I've been in a lot of Zoom meetings, but presenting virtually, and my family was teasing me because if you saw me, I am broadcasting live from my kitchen, and had to put a sign on my front door because between my husband and my daughter, there are daily deliveries from Amazon.Prime, and I had to put a sign on my door, please don't knock on the door or ring the doorbell because I'm in a meeting. And so we definitely are facing lots of challenges and will continue to do so. I want to share a little bit how I got interested in this topic. I became a nurse actually when I was a little bit older. Nursing was a second career for me. And by the time I became a nurse, I had 3 young children, and I started my career in the post-anesthesia care unit. And I actually was very surprised at what I found when I came into the nursing field. I had worked in other professions before, but I just was taken aback by the way that nurses treated one another. And so I decided, after being in a staff nurse position for many years and becoming the nurse manager of the unit, I wanted to do something to help my units be healthier. And so even though for many years we have been talking about bullying and incivility in the workplace, we have made some strides, but there are still issues. And recently, a very good friend of mine named Tammy became an LPN, and she's my age. And she said the same thing to me. She called me a couple weeks ago, and she was very upset because she started a new job and she's been experiencing bullying. And so I was giving her some advice, and she said, I've been in other professions and I just couldn't believe when I went into the workplace some of the unprofessionalism I was experiencing. And she was very, very disappointed. And so I'm going to share her story a little bit later on, just to show some of the things that are continuing to happen in our profession. I also want to share that all the tools that you will see today are tools that I use. And what's great about being a consultant for the Healthy Workforce Institute, excuse me, is that I get to use these tools every day. I use them as a manager, I use them as a director, I use them as a staff nurse, and I believe in these tools. I took over my position as director of the operating room in April of 2019, and our engagement scores had just come out. And I wasn't part of it then, but I got to see the engagement scores. And although the PACU and short stays and engagement scores were very good, I oversee the operating room PACU short stay, pre-hospital assessment, central sterile supply, and anesthesia group has a dotted line to me. The OR's engagement score was 14%, which put them at below the 5th percentile. Even during COVID and during this pandemic, we recently took another engagement score. And even in spite of this pandemic, our engagement score went to 61%. Now, although that is below the benchmark, we did make it to the 20th percentile. And even amidst a pandemic, we were able to make some improvements. Now, I'm not here to tell you that all these tools are going to work right away, but it can be very slow, and sometimes I tend to be impatient, but I use these tools every day, and I will continue to use them with my teams. And the stories that I'm going to tell you are real life. You've heard the expression, you can't make this stuff up. And so any example that I give to you has either been shared with me through people that I've done workshops for, or through my own experience as a leader and a staff nurse. So what will you learn today? Our goal is that by the end of the day, or by the end of this workshop, you will be able to recognize the difference between bullying, incivility, and someone having a bad day. And there actually is a difference. There was a time when I used the words bullying and incivility interchangeably, but they are very different, and we're going to talk about that today. You're going to learn a few simple confronting techniques to stop disruptive behaviors in the moment. And then we'll end up the workshop by discussing a couple strategies to cultivate a nurturing, supportive, and professional work environment. Now, before we actually get into the presentation, and I don't like to use a lot of statistics, but I want to set the tone about why we're here today and why we are talking about this topic. And you can use your chat feature to answer this question. And I do know there's about a 4 to 5 second delay, so there could be a little bit of silence, but I think that'll go by quickly. So during the previous 6 months, what percentage of nurses admitted to being bullied in the workplace? So just think about that. We have a whole conference devoted to civility and incivility. What percentage of nurses do you think admit to being bullied in the workplace? It's hard to actually see. I'm looking at the YouTube here, and I'm seeing if people have responded to this. I'm just going to give it another couple seconds. And I'm going to refresh my screen too, because I know that can be an issue. Oh, good. There we go. We got it. Thank you. All right. See a lot of different answers here. Diane says 48%. I see a lot of 48%. I see 35%. Beverly put 35%. Thanks. We know this is working. Great. Well, guess what the answer is? The answer is 48%. So almost, let's just round it to 50%. Almost 50% of nurses admit to being bullied in the workplace. And if we were able to poll all the participants today, you might find that half of the nurses will say that they have been bullied. And that's very startling when you think about it. Let's look at the next question. This is for my OR people out there. What percentage of perioperative personnel reported decreased concentration, reduced communication, collaboration, and impaired relationships with other team members as a result of disruptive behaviors? It seems like I have to refresh this every time I want to hear. So let's see what we have. Okay. Joyce says 60%. I see a bunch of 80%, Francis and Suzanne. Well, guess what? The answer is 80%. 80% of staff report reduced concentration. Just think about that in terms of safety. And as the director of the OR, I can exactly see how this might happen with disruptive behaviors. Last question, and then we're going to go into a little bit more detail about this. How many people die each year from preventable healthcare errors? The key term in this is preventable. The answer to this question is 250,000 patients die every year from preventable healthcare errors. Now let's go into a little bit more detail about that. I love to show this slide. This slide actually comes from the National Patient Safety Board. This slide I saw quite a few years ago when the chief medical officer at a hospital in Dallas, who was a patient safety officer, shared a presentation on disruptive behaviors in the workplace. This is what's important to remember. When you look at this slide and you look to the far right, what's in blue? The items or activities in blue are relatively safe, meaning if you engage in them every single day, the chances of you being seriously injured or even dying is very minimal, and that includes scheduled commercial airlines, European railroads, and nuclear power. I love to remind myself of this because prior to the pandemic, when we had conferences and keynotes, I would fly, and I don't like to fly, and I actually know that my fear of flying is quite irrational. So I always think about this slide when I'm about to get on an airplane, knowing that it's very safe. Now, as you move to the far left, these activities become less safe. Driving in the United States, chartered flights, and chemical manufacturing. I also remind myself, I live in York, Pennsylvania, which is about 50 miles north of Baltimore, Maryland. So I typically will fly out of BWI. And sometimes my husband will bring me or one of my daughters will take me, but I always remember too that I have more of a chance dying in traffic or getting in a bad accident than I do on a scheduled commercial airline flight. So again, these are not as safe, those areas that you see in the middle. And then let's look to the far left, mountaineering and bungee jumping. And when I'm out presenting live, I like to ask people, how many people have ever gone mountaineering or gone bungee jumping? And where I saw the most hands raised is when last summer, not this summer, but the summer before, I was in Santa Monica, California presenting, and of course in California, where there's a lot of outdoors activity. And I did have quite a few people who had participated in mountaineering and bungee jumping. Now, what they say, what this slide tells you is the more you participate in this activity, the bigger chance you have of dying. These are unsafe activities. But for me personally and for my family, it doesn't bother me. I'm not afraid because I don't think, unless I have some big change of heart, that I will ever participate in mountaineering or bungee jumping, or my family. So I'm not super concerned about the safety of these activities. Well, let's look at healthcare. You have more of a chance of dying when you step into any hospital in this country than you do of mountaineering or bungee jumping. You know what that means? That is the equivalent of a jumbo jet crashing every Monday, Wednesday, and Friday. And we would certainly be paying attention to those statistics if that was happening, right? What's different about healthcare than mountaineering or bungee jumping is that there is not one person that hasn't used healthcare or is going to need healthcare at some point. And look at what our statistics are. And so if this does not give you pause for just a second to say, why are we here today? Why do our work environments need to be healthy, other than the fact that it is great to be nice to one another? But what is the ultimate goal? Is to take great care of our patients. There was a recent study that showed that 71% of nurses and physicians contribute incivility to patient death. 71%. And I don't know about you, but I or my team, I do not want to be responsible for the death of someone's grandma or grandbaby or husband or wife or loved one, just because as healthcare providers, we do not know how to take care of one another. And at the Healthy Workforce Institute, what we say is the way that we treat each other should be just as important as the care we provide. Let's talk about why bullying is so prevalent in healthcare. I don't think I have to tell anyone who's in this audience, no matter what your role is in nursing, is that we work in a stressful work environment. We are dealing with life and death issues, and now pandemic issues every single day. And so we are never going to get away from the stress of healthcare. COVID may pass or things will get better, but something else will come along that makes our profession very stressful. And so what do we need to do? We need to find a better way to support one another in our stressful work environment. A couple years ago, I read a book called The Wisdom of Wolves. And this is what I learned. Did you know that wolves are more devoted and committed to their family than any other mammal on earth? Each member takes full responsibility for the well-being of the pack by supporting one another. As nurses, as a profession, we need to have a wolf pack mentality where we support and care for one another despite the hardship and stress that we face. Because what we need to remember is nursing is never just about one nurse. It is the collective impact we have as a profession on our patients. Why else is bullying so prevalent in healthcare? Well, 90% of the 4.1 million nurses are female. And for the ladies in the audience, and I'm sure there are gentlemen too, what am I going to say? We are not always nice to one another. Many times we are labeled as catty and cruel, and that's just the way we are. Now, I am not here to say that men don't bully, because they do. And as a leader, especially with the PACU, I have had the opportunity to have quite a few male nurses work for me. And there has been incivility and bullying. And I say this somewhat tongue in cheek, but with men, if they have a disagreement, they'll take it out to the parking lot, they'll throw a few punches, they'll shake hands, and they'll be done. But with women, many times, we will hold a grudge for the next 20 years of our profession. And many times it is over something more interpersonal than rather a clinical issue. Again, that is a general statement, but in being in this field for 21 years and in being leadership for quite a few of those years, I can pretty much say that is what I have seen. And many of you may or may not agree. And there's also the hierarchy. We truly have moved from what would be considered a physician-dominated culture to a culture where we are all held for the outcomes of our patients. And so when we're stressed, when we're feeling a lot of angst, who do we take it out on? We take it out on the people that we are working elbow to elbow with. Why does bullying continue? Ask any nursing student, new or experienced, if they've ever heard the expression, nurses eat their young, and they will raise their hands. And why is that? It is because we have normalized these behaviors. It's like the old saying about what happens if you drop a frog in boiling water. If you drop a frog in boiling water, he's going to jump right out of there because it is too hot for him to handle. But if you take that same frog and you put him in cool water, and you slowly turn up the temperature, what's going to happen? The frog is going to boil to death because he does not realize how toxic his work environment has become. And what happens then to people that survive this incivility and survive this bullying? Maybe for 10 years, they work in a very unhealthy work environment. And one day they switch and they work maybe in something that's a little bit healthier. If for the whole 10 years of their career, all they've seen is incivility and bullying, then they may have adopted or adapted and have some of those traits, and they may become the nurse they never wanted to become. A couple years ago, I was in Texas giving a workshop on assertive communication to the operating room, which is a very large staff. And after the presentation was over, which is the case in many cases, people will come and talk to me afterwards. A young woman by the name of Cassandra, and I have her permission to tell her story, came up to me. And she was obviously very emotional. She had tears in her eyes. And she said, "Diane, can I tell you my story about nursing?" And I said, "Absolutely." She was a young woman, maybe in her early 30s. She said, "My father was very ill and he was in this hospital. And every day, whenever I had a break or lunch break, I would go up and see him." And she said, "This hospital is a very big hospital. So it isn't likely, like in my hospital, I work in a small community hospital. I come from a level 1 trauma center, 580 beds. But in the same healthcare system, I'm now in a community hospital, about 150 beds. So most people, when you see them, you know who they are. But in this hospital, people didn't always know one another. So one day, Cassandra went up to see her father during a break that she had. And she was in a uniform, of course. And she walks into her father's room, and immediately the nurse says, "Oh, you know this patient. He's non-compliant. He's a brittle diabetic, and he's obviously morbidly obese." And I know I can't see all of you, but I can almost see your reaction to that comment as I say it. Right away, Cassandra just said, immediately she didn't know what to say. And then she said, "I'm not here to take care of that patient. That is my father." And the nurse's jaw just dropped, and she immediately apologized. Now, we're going to talk about positive intent in a little bit. And although I'm very big on wanting to assume positive intent, in this instance, the way that rolled off of her lips, I want to say maybe she wasn't apologizing because she was truly sorry, but she was apologizing because she might have got caught. And so Cassandra said to her, as she kept apologizing, she said, "No, that's okay. Just stop." She said she didn't get angry. She just looked at her and she said, "In that moment, I saw me in you, and it's not the kind of nurse I want to be." And when she went home and she told her husband, who was also a nurse in that facility, he wanted to report that nurse. And Cassandra said, "No, we're not going to do that. We're going to be better nurses because of this experience." And she said, coming to the workshop that we were doing, it was validating what she was trying to do and being a better nurse and being more civil and speaking up, because she said, there's that expression, scrub the hub before you give a medication. And she said many times her colleagues wouldn't do that. And she spoke up, and she did so respectfully. And so isn't it great that maybe we can learn something from Cassandra, but look at the way Cassandra had to learn. And we keep in touch, and she says things are going better, and she's really growing her skills in communication. We also have a fear of retaliation. You can have the best HR policies in the world, but people will find a way to retaliate. A couple weeks ago, one of our surgical techs, and those of you in the audience, I don't know if you have the same issue that we do, but surgical techs are hard to find and hard to come by. And Brooke, our surgical tech, decided to leave. She's a young mom with quite a few children, and she found a job in an outpatient center, more money, better schedule, no call, no weekends. And so she just decided to take that opportunity. But I like to do stay interviews, but I also like to find out why people leave. But I also asked her what her feeling was about how things were going in the OR. And although she felt things were going better, she said there were still issues of bullying and incivility, and she hoped that I could continue to work on that with my team. And I said, "Brooke, but what do you do when you see this?" She goes, "I don't say anything." And I said, "Why not?" She goes, "Because I'm afraid. And I just don't want to get involved." And I said, "You do understand, though, that as a peer, you have accountability in speaking up." And so those are the things that we have to work on with our teams. And then last but not least, silence as a strategy, which Brooke was also using. It's better not to say anything than to have to address bad behavior. And there was a study that showed that 50% of people don't even know how to respond to bad behavior or something that's uncivil. And we're going to talk some more about that today. We recently started some of the classes in our operating room to address all these things: gossip, assertive communication. And our first class was on assertive communication in the operating room, and it actually went quite well. But one of the things I said to them is, I know that you want change, positive change in terms of our culture, but there is no change without change. If you sit here and you say, yep, if Susie wasn't here, or if Joe wasn't here, or if Jane just would keep her mouth shut, this would be a better place. But no one is saying, what can I do for this to be a more civil work environment? And that's where the change. You can sit there, but if you're not going to make any changes, you will not see a change in your work environment. So what's the impact? Decreased retention, increased costs, threat to patient safety, low quality care, and poor patient satisfactions. New nurses who quit their job in the first 6 months, it's because of bad behaviors of their coworkers. In the first 6 months, new nurses. Most of you know in nursing, we can't afford this. We have shortages as it is. And what's even more startling is 20% of nurses will quit the entire profession in the first 3 years due to bad behavior. They can't take it anymore. What we know is culture is more important than a paycheck. And if they don't quit, they disengage, which may even be worse. It costs healthcare organizations $3 billion a year to deal with the effects of incivility in the work environment. And you will never achieve your patient experience scores if you have a bullying problem. So let's talk about some of these behaviors. Now, this is not the exhaustive list, but see, these are some of the top behaviors, bad behaviors we see in healthcare. And the first couple ones are overt. They are in your face. You know what's happening. It's yelling, it's screaming. Public criticism is number one. I bet you every single nurse in this audience can share an example with me where they were criticized or witnessed it. When I was a brand new nurse within my first year, I worked second shift and I was bullied as a new nurse. And here I was like 35 years old. I had a family, I had life experience, and I consider myself an assertive person, but I was bullied. And one night a patient came down from the floor and went to the OR. He was a gentleman in about his 60s. And he had a PCA, and the surgeon said, I'm going to renew his PCA after the surgery. And so 2 hours went by. The patient came out of the OR, I got report, and my partner brought over the PCA. I checked the orders, and sure enough, he had renewed the PCA, hooked it up. About 20 minutes later, the charge nurse, who was the nurse that had been bullying me since I started and continued to do so until I spoke up, looked at it and said, Diane, this is not that patient's PCA. And I said, what? I had made a medication error. My partner had brought me the PCA, but at the bottom in that tubing was the label of a different patient. And in that moment, she started to yell at me. She told me I was incompetent and that I would never make a good nurse. What do you think I did? I started to cry. Not big sobs, but here I am taking care of a fresh post-op patient, the most dangerous time, the most vulnerable time for a patient, and I was in tears. Going back to preventable errors, and 250,000 patients die every year. My patient didn't die, but I'm saying you can understand how this can happen. And working in a level 1 trauma center, we were busy. There were 7 or 8 of my peers there. That night, do you think one of them spoke up? No. Why? Because they were afraid. They were happy that they weren't the target at the time. That's public criticism. There are threats. I worked with a team once where a nursing assistant told a nurse in the middle of the unit, I know where you park your car. And you know what's sad about that? Guess who reported the incident? A patient's family member, not her team. Again, why? Because they were afraid. When they were called about it and asked and interviewed about it, they were honest about what they had seen, but they were not the ones to report it. There are ethnic jokes and slurs. I once was working in a very small hospital where there was this bathroom that was way out of the way, and all over the stalls and on the walls. And it was there were ethnic jokes and slurs that they tried to have removed for many, many months, but they remained there for a long time. And then we also have blaming, and we have the silent treatment. And we know that in order to take good care of our patients, whether we care for our coworker or not, we need good communication. Now let's talk about behaviors that are really hard to wrap your head around, and these are covert behaviors. Our staff, if you're in the audience and you're a leader, our staff see this all the time. But as a director, as a manager, these are the things that we aren't always going to see. And that's why it's so important to teach our staff how to speak up. And those are the tools we're going to talk about in a little bit. The first one is withholding information. As a nursing student doing my ED rotation 21 years ago, I worked evening shift, and it wasn't my preceptor. My preceptor put me with another nurse that night. And they brought in a gentleman who had been found passed out, inebriated in the city. And they brought him in, and being a nursing student who's told, like, you know, we don't always get our hands dirty. Like we're book smart, but we don't take initiative. And I'm like, I'm going to take initiative. And I asked to start the patient's IV. And the nurse I was working with said, sure, you can start the patient's IV. But there was this, an EMT named Chris, and I remember him very well. And he said to the nurse, well, just keep an eye on her, because you know this patient, you don't know what's going to happen. And she's like, she'll be fine. She'll be fine. And Chris walked away down this long hallway. And as I got my stuff ready and I started the IV, the patient was he was passed out, but he woke up pretty quickly. He punched me in my eye, and I had a big black eye. And Chris, the EMT, comes running down the hallway. He's like, are you okay? Are you okay? And the nurse, the CMT said to the nurse, or the EMT said to the nurse, I told you to keep an eye on her. You know this could happen. Finding out that this was a gentleman who was frequently in our emergency department. And you know what that nurse said? She said, sometimes you have to learn the hard way. Imagine that. To me, in this day and age, that would be grounds for dismissal, because how did she care about that patient? She put me at risk. She put the patient at risk. She put a lot of people at risk. So we see that a lot, withholding information to sabotage people. We have exclusion. Do you know that when people are socially excluded, the pain centers in their brain light up? It is physically painful to be excluded from our work groups or from any group. They're sabotaging. Years ago, I listened to an OR nurse speak, who's now a speaker, that said she was in the OR one day with I would say a queen bully. And the queen bully had a new grad. And when she set up the instruments for the surgeon, she put an incorrect instrument. And when the new nurse handed the instrument to the surgeon and it was the wrong instrument, the surgeon, of course, got very, very angry. And of course, the queen bully said, yeah, students coming out these days are pretty stupid. Again, where's the compassion? Forget the fact how she treated her new employee, but she put that patient at risk. What if something happened in using the wrong instrument? It was caught, but just imagine that. This is what sometimes I can't wrap my head around some of this stuff. There's backstabbing. People say one thing to your face and they're setting booby traps behind you. And then we hear a lot about unfair assignments. Right now, working with a hospital in a different part of the country where it's been pretty much determined that the charge nurses on this one unit are pretty much part of the problem. The floor is called the liver floor. These patients are very, very sick. Even the sickest of the sick is not your best assignment. But what we found out in doing an assessment is that when nurses are driving to work, they'd actually call the charge nurse and say, hey, I'm stopping at Starbucks. What can I get for you? Just to avoid getting the worst of the worst assignments. So these are all examples of covert bullying. Now, don't we all wish that when we have new nurses on our team or any new team member, that we could treat them like the mama puppy treats her babies? But what we see is more of what we see with the cats, just baptism by fire, toughen up your skin and things like that. And what's interesting, as the video was playing, I got to look at some of the chat, and it is sad. I mean, you're validating what I'm saying, but it's sad to see that many people are saying a lot of the things I'm saying, you've seen. And what doesn't make sense about that is that we are considered the most ethical profession and the most compassionate profession. That's what the public says about us. But do they know nursing's dirty little secret? And that's what it's called in the literature. And so I love that video. It's fun. Wanted to break it up a little bit too. But as I look at the chat room, it is very sad to say, yes, I see that too. I don't have time to go into it today, but I have a lot of stories surrounding food in an operating room and the drama that it's caused. It's unbelievable, but I see people commenting on that. It's very interesting. So now we've talked a little bit about what some of these behaviors are, but what is it? Bullying, incivility, or is it someone just having a bad day? Because as I mentioned earlier, there is a difference. And let's get clear. How do you know your coworker is a bully, a drama queen, or just being a jerk? Someone who's having a bad day and lashes out recognizes it and they apologize. But a bully never apologizes. They justify their behavior. Let's get clear on the definition of bullying. Bullying is a repeated pattern of disruptive behavior with a conscious or unconscious attempt to do harm. In order for bullying to exist, there has to be a target, it has to be harmful, and it has to be a repeated pattern of behavior. In other words, if I do something unintentional, hurtful, and I just do it once, that was just rude, I probably owe you an apology, but it was unintentional. When I say or do something intentionally, and I did it to hurt your feelings, then I am just plain mean. But if I say something or do something intentionally hurtful, and I do it over and over and over again, even though you've asked me to stop, then that's bullying. Incivility, on the other hand, are low levels of unprofessional or rude behaviors and a general lack of respect for others. In all honesty, this is what I see more in healthcare. Bullying does exist, but based on the definition, to me, it's pretty, I don't want to say easy. It's a little bit easier to hold people accountable. But what we see is this: people not saying good morning, people ignoring you, people eye rolling. But that's what it is. It's the eye rolling, the mocking, the condescending body language, helping people you like, not helping the people you don't like. Incivility can lead to bullying. Bullying is addressed by your workplace policy, your code of conduct, or a just culture. Incivility, on the other hand, is addressed by changing your culture and addressing these types of behaviors. Let me go back for a minute. One thing that we need to know is if you're in a leadership role is that we need to role model these behaviors. If you have a leader, and I know there's lots of other people, to me, all nurses are leaders, whether you're in a formal leadership role or informal. But in terms of formal leadership roles, it starts with us, and we need to role model those behaviors. And one of the things I did with my own OR is to set the tone. And this is what I said to them, just an example. I will accept personal responsibility for establishing and maintaining interpersonal relationships with each and every one of you. I will speak with you directly if I am having an issue or a concern while keeping in mind our core values. And where I work, our core values are respect for all, assume a positive intent, working as one, finding a better way, and doing the right thing. And last but not least, I will be committed to finding a solution rather than complaining or blaming. And I ask you to do the same. And so that's how I started off with my team and my leaders. And I gave them permission to also, If they feel I've been disrespectful or I am not being kind, kindly tell me. Also, you have to give permission that we all need to hold each other. We, as leaders, we are not above having bad behavior or bad days. But what bullying is not? Bullying is not constructive criticism. This sometimes shows up if a new nurse claims her preceptor is bullying her. It could be true, but many times it's just constructive criticism. It's not being held accountable for your performance. You're allowed to have conflict and different opinions, and sometimes you just have a bad day. And that's what I want to talk a little bit about, is having a bad day and giving grace to people. It is very difficult for us to orient to another person's perspective, to understand why they say what they say and why they do what they do. We are hardwired to more harshly judge others and more favorably judge ourselves. A really good example outside of healthcare is this, and it almost makes me laugh. There was a study done recently where they asked drivers to rate their driving ability on a scale from 1 to 5, 5 being the best. And guess what? 93% of drivers gave themselves a 5. Now chew on that one for a minute. Anybody who drives. Where I worked at my previous hospital just 18 months ago, I could walk to work. I now drive about 80 miles a day, and I have become a commuter. And if 93% of drivers are excellent drivers, I don't know what's going on, because I've seen more accidents, more road rage, more close calls. But there you go. We favorably judge ourselves. Now let's talk about it when it comes to work. If you have a coworker that is always late, what's said about them? They're lazy, they're uncommitted, they don't care about the team, right? But if you're late, it's because you hit traffic, your kid threw up on you as you left the house, your dog is sick. We evaluate others in terms of character and character flaws, but we evaluate ourselves based on the situation. And that is where we need to give grace. We do not give others the same grace that we would want for ourselves, and that can go a very long way. So now that we've talked a little bit about bullying and incivility, I'm going to give you a couple of quick scenarios. And based on those 3 things, target, harmful, repeated pattern of behavior, I want you to let me know what you think it is. So here's the first scenario. And I'm going to refresh the chat room real quick because it seems like I have to do that. So sorry about that. Donna and Michelle usually get along. However, today they got into a heated discussion about staffing. The discussion ended when Donna grabbed Michelle by the arm and then walked away. So remember, target, harmful, repeated pattern of behavior. What do you think this is? Is this bullying? And if it's not bullying, what do you think it is? Not sure I see any responses right now. I just refreshed, but this isn't bullying. And I want you to take it for face value. Is there a target? Yeah, you could say Michelle is. Is it harmful? Yeah, you shouldn't be touching another person. Is it a repeated pattern of behavior? Not that we can tell. So really this is just it's a single act of aggression. Does it have to be addressed? Absolutely, but it's not bullying.
And Diane, this is Janet. If I can just share with you, because I'm looking at the screen, so I wanted to share some of the responses people had given. Many said it's incivility, bad day. No, it's not.
Let's talk about the next one. I just want to make sure no answers came up in the first one.
Assault.
Oh, you got it. Yeah,
Right.
there is definitely a little bit of a delay. I see.
There is.
It's not bullying. It is workplace violence. Someone having a bad day. Yeah, it could be someone having a bad day. I like that. It is physical assault and it has to be addressed, but it is a one-time thing. I'm not dismissing what it is, but just trying to differentiate. The next one, in this morning's unit huddle, you notice that as your manager discusses the unit's new culture of caring initiative, Christy, one of the experienced techs, rolls her eyes and whispers, "Just another flavor of the month." What do you think this is? Keep changing this. Absolutely. Oh, we got winner, winner. Lots of people said incivility. Absolutely. This is incivility. This is what we see more of. And what I find interesting about this is that when I was a new manager, I had a Christy, let's just call her. And I noticed when we had staff meetings, she was the one in the back rolling her eyes and having these sidebar conversations. And one day after we had a couple meetings, the charge nurse said to me, "Oh, Diane, don't worry, that's just Christy." And she'd been there for like 10 years. And I said, "Well, has anyone ever talked to her?" "I don't think so." So I actually called Christy, see if I could talk to her. Not in my office. She don't want to go to the principal's office. I asked to have a cup of coffee with her. We should stay away from our offices when at all possible, if we can keep things confidential, because it does have this perception of you're in trouble. And I said, "Christy, hey, I don't know if you're aware of this, but in the last couple staff meetings, you're in the back, you don't really participate, but I see you having sidebar conversations and you're rolling your eyes. What's going on?" And she admitted to it and we talked about it and she apologized, but there was some self-awareness. And I don't want to tell you that Christy did a 180, but I did see improvement. But I thought, she's been in this unit for years and nobody talked to her. Now, one could say people were fearful of it. One could say, well, you're the manager, you could talk to her. But again, if we all have those skills, we'll find improvement in that. But look at all that wasted time and the perception of Christy when no one really said, "Hey, what you're doing is not cool." So definitely incivility. And it looks like everybody got that one right. Here's another one. Every time Sierra follows you, she refuses to take report from you. Once she made the comment, "Trust me, there's nothing you can tell me that I can't find out for myself." Despite your insistence that she take report for the sake of the patient, she refuses. However, you notice that she takes report from everyone else. Is this bullying? Just waiting for some of the answers to come in. Definitely is a little bit of a delay. Sorry about that. But I think you guys are going to get the right answer on this. Yes, 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 yes. Definitely bullying. A target, it's harmful. And who's it harmful to? Not only is it harmful to the nurse, but it's ultimately who suffers, the patient. And it's definitely a pattern of behavior. And then the last one. You notice that when you follow Jerry, the newer radiology tech, he frequently leaves the side rail down on the stretchers. When you confront him, he claims you are bullying him. Is this bullying? Very good. Right. It's not bullying. It's constructive criticism. It goes back to what bullying is not. Now, if you yell and scream at Jerry, that's a different story. But if you're just saying, hey, Jerry, I noticed that, you know, you don't leave the side, you leave the side rails down. You need to put them up. That's constructive criticism. All right. So let's talk about some strategies. We talked about the differences between bullying and incivility, and what you're here for is, all right, what do we do about this? How can we make some positive changes? Well, many of you are here, and we have to heighten awareness. When a patient is admitted to the hospital, you need to do a full admission assessment in order to safely and effectively care for the patient. You need to do the same with bullying and incivility in your workplace. You need to start paying attention. Years ago, the Institute of Medicine said the best way we can improve our healthcare system is through building trust. That was in their white paper. And the 3 biggest destroyers of trust, guess what number 1 is? Gossip. Gossip, number 1, Institute of Medicine says. Number 2 is breaking the confidence of another person. And number 3 is the inability of peers to give feedback to one another in a respectful and constructive manner. And on the note of gossip, I like to give this little tip for people if you're tempted to gossip, and ask yourself these 4 questions. Would I want this said about me? Does this escalate a negative story that might be already circulating about this person? Number 3, am I saying this to put another person down? And last but not least, this is the one I like the best. Does it feel right in my gut when I say it? So ask yourself those 4 questions. I've used it myself. Just because I train on this stuff and I believe in it, it doesn't mean I'm not human. And I have used this when I've been like, oh, it's fun sometimes to be part of the juicy information, right? And you have to stop yourself from doing it. And we need to set behavioral expectations. As a healthcare profession, we are very good at setting clinical expectations, but we do a terrible job at setting behavioral expectations. Many of you may agree that some of the most clinically competent people you have ever met or worked with are the most toxic. And I can say that in some cases, not everyone, but in many cases. There's a book I love by Brene Brown called Dare to Lead, and many of you as leaders might have read it, but there's something in there that's so apropos to what we're talking about today, and I quote her as I say this. We avoid tough conversations, including giving honest, productive feedback. It could be a lack of courage, a lack of skill, or just our cultural norm of wanting to be nice. But the consequence is lack of clarity, diminished engagement, and an increase in bad behaviors like passive aggressive behaviors, talking behind people's backs, the meeting after the meeting, and the dirty yes. You say yes to my face, but when you walk out of here, you say something totally different. Not getting clear with a colleague because it's too hard or because you're afraid, yet you hold them accountable and you expect them to perform is unkind. Clear is kind, unclear is unkind. Failure to speak the truth about issues directly to the person involved winds up in silence and hostility, and neither one of those is a healthy option. So let's talk about some of this education. When I do workshops, when I'm there, and sometimes these workshops are 3 hours long and we do a lot of practice, we have to confront these bad behaviors. And today I'm going to give you a couple of tools to confront behaviors. Now, what's funny is that my team over the year has said to me, oh, but Diane, you're good at it. Nope, that's not what it is. What I know is that I've become comfortable with being uncomfortable, because there is not a conversation, a courageous conversation that I've had that I've ever was like, man, I really nailed that. I'm great at this. It's just that I will actually say to people as I have the conversation, whether it's with a physician or one of my leaders or a staff member, is, you know what? This is really going to be uncomfortable for you to hear, and it's uncomfortable for me to say, but we need to talk about it. And it can't just be leaders. Every individual, from nursing to physicians to ancillary staff, need to be able or need to have these tools so that they can speak up respectfully. Now, the first one is Name the behavior. This is one of the tools. You need to name it. It is not enough to say to someone, you're mean. What does that mean? I don't even know what that means when you tell me I'm mean. Just like I had the talk with Christy, people said she was uncivil, but I said, you know what? I see you rolling your eyes, you're having sidebar conversations, but I did it respectfully and I did it in private. So something like, I just saw you roll your eyes at me. Or you're yelling at Candace in front of people. We agreed as a team that we would never yell at each other publicly. Candace is new, and she would benefit from you speaking to her privately and respectfully. Can you tell me what happened? Are you okay? So when people hear about confronting things, they think automatically that you can't show caring. But I love the quote, and I forget where I saw it, is that we need to care personally, but challenge directly. By saying, hey, this is what I saw, and you give them specific behaviors, you name it, but you ask them if they're okay. Maybe they are just having a bad day. Other ways to say this is, I know this is a tough conversation. Being angry is okay. Yelling is not okay. I know you are tired and stressed, right? Aren't we all, especially now? Being frustrated is okay. Interrupting people and rolling your eyes is not okay. I appreciate, this might be in a staff meeting, I appreciate the passion and different opinions and ideas that are going around. That emotion is great, it's okay. But the passive aggressive comments and the put downs are not okay. So you're allowing people, it's not saying they can't have that emotion, it's how they deal with it. And this is giving them the tools. So the first one is naming the behavior. Then we have assertive communication, right? Do you know that the most widely used communication we use in healthcare is passive aggressive? But assertive communication is honest, it's respectful, and it preserves relationships. Do not say assertive and aggressive communication are not the same. Assertive communication, I can voice my opinion, but I have respect and will listen to other people's opinions, right? Assertive communication, you're not out to hurt others. In assertive communication, you don't say, I want to win this argument, even though sometimes you do. My family will say, I always want to win the argument. But that's not what the purpose of assertive communication is. It's to come to common ground. And do you know that assertive people are healthier? They're healthier professionally and personally because they don't hold all that in. They speak up and they get things out on the table, but they can do it in a respectful manner. And then there's scripting. This is my favorite. Now, how many times have any of you been in a confrontation? You didn't know what to say. You didn't say anything. You lashed out, but then you get home and you get in the shower and you're washing your hair and you're saying, oh, I should have said this. I should have said that. Well, there's ways you can do that. Now, many times, some of these things can't be addressed in the heat of the moment. Now, if two nurses are yelling in the middle of a nursing unit where patients and families can hear them, you need to stop that right away. But if it's a courageous conversation, if you work with people long enough, you know how they're going to react. I knew the nurse that would cry when I addressed a behavior. I knew my nurse, James, who was somewhat passive aggressive, that would get very defensive. And so I'd be prepared for it. I'm not saying you can be prepared for everything, but you can be prepared for some things. So some of these lines are, help me to understand, and then what that might be. I'm not sure you're aware of this, but sometimes you come across as a little abrasive, and be specific about what that abrasive behavior is. Sometimes a comment is so offensive, you just say, I'm offended by that comment, or I'm not even willing to respond to that. So to take that a little bit further, what might you say to an experienced nurse when she makes it obvious that in many ways she has no patience for you as a new nurse or someone who's new to the unit? You might say something like this, and these should always be done in private. I noticed today that you seemed bothered by my questions, and I felt in the way. I understand you have a heavy workload, but when you ignore me, I feel terrible. I get the message you don't want me here. I want to learn and I want to be a great nurse, but I can't learn in this environment. Nothing aggressive, I don't think, about that statement, right? What do you say after you hear someone is backstabbing you? Remember what the IOM said, gossip, number one, to destroy teams. I'd like to talk to you in private. I heard from another nurse that you did not you said I did not know what I was doing and that I was a terrible nurse. When I hear someone has been saying things about me and I don't know why or what the situation is, I feel sabotaged and set up to fail. I want to be a good nurse, but in order to do that, I need your honest feedback. Can you please speak to me directly when you have an issue with me? I need that support from you. Again, not aggressive. What might you say to a nurse who is being unkind to the nurse that he or she is precepting? Help me to understand why each time I see you give report to our new nurse, Kate, you answer her questions curtly, you don't make eye contact with her, and yesterday I actually heard you say, just look it up in the chart. Again, you're being very specific about those behaviors as opposed to, you're just mean to our new nurse, Kate. Again, the words, what this takes is moral courage and practice. What I did my master's on many years ago was the importance of didactic learning, like, hey, you're in a class and you're learning, but cognitive rehearsal and actually practicing. And that's what we're embarking on right now in our operating room. How about with a doctor? When I was brand new to my role as a director, I had an anesthesiologist, I'll just call him Dr. Burke, and he would just storm into my office and just yell at me about something and tell me to fix it. And even me, who's pretty assertive, on the third time I said, oh, I'm not putting up with this anymore. So he came in one day and I said, Dr. Burke, I'm not sure you're aware of this, but each time you come to see me, you charge into my office, you don't even say good morning, you drop a bomb on me, and then you leave and you tell me to fix it. I'm new here because I really want to help you. I want to address the concerns of the unit, but I find your approach to be disrespectful. So what can we do to work this out? And in his typical fashion, he did apologize to me, but you know what? A week or two later, similar situation happened, but he came to my office and, our brain goes to what we're comfortable with, but he stopped because I kind of looked at him and he came in, he goes, good morning, Diane. And he sat down and we talked about it. Now, is he always like that? No. But what I appreciated is his self-awareness and that we continue to point it out. But if I had not said anything for the rest of my time as director there, he never would have changed his behavior because I wasn't telling him that it wasn't okay to treat me that way. So let's practice a little bit. So as I read these scenarios, there's going to be 3 answers, A, B, and C. And there'll be a right answer, but I want to talk a little bit about some of the other answers. And as we go through this, there's 3 scenarios. I want you to think about what your go-to is. Like, this is what I'm comfortable doing or what I have done. Because nobody's, this is just for you, for your own learning. But what I want you to put the right answer down, if you can see what it is. I don't think they're too hard, but what might be our comfort? And some of them aren't really wrong answers, but it's how we frame it. So you are the charge nurse today in the operating room. 2 of the surgical techs approach you and ask you to be reassigned because they do not like the surgeon. When you ask why, they both say he is very condescending and no one likes to work with him. Here are your answers. Do you reassign the 2 techs because you know the surgeon's behavior is never going to change? Do you tell the techs to give the surgeon feedback that you do not appreciate being talked down to? Or C, explain to them that you need for them to keep their assignments and assure them you will follow up with the surgeon. Put down your answer and then we'll talk about some of the other ones. Okay, let's see. Lara says B, empower them. I see Lanny, Louise, Melissa, Jennifer all say C, and I don't see any A's, but I see some B's and C's. So this is really interesting, and I'll tell you why. The mostly correct answer is C, and I'll tell you why. There's nothing, A is definitely out, and I've seen my charge nurses do this. We've worked on that. Like, that surgeon's never going to change, so it's just easier, right? Silence is, just let them go. Depending on the maturity of your unit, in all honesty, B would be the best answer. Tell the techs to give the surgeon feedback. But again, in a very mature unit that's done a lot of work on communication, that absolutely would be the right answer. And I do know surge techs that could give feedback to surgeons. But let's just say you're taking baby steps. It would be best to explain to them that you need for them to keep their assignments and assure them you will follow up with the surgeon. And this actually happened in my unit. That's why I used it as an example. My charge nurse, Anna, one day had 2 surge techs say, we don't like to work with Dr. E. And I actually knew this surgeon from my previous hospital. He goes to different hospitals. And I could understand he can come across as condescending. And she said, I talked to him one day and I said, I'll just call him Dr. Smith. Anna, the charge nurse, said, Dr. Smith, can I talk to you for a minute? Again, scripting. She said, I'm not sure you're aware of this, but some of the techs, they really don't like to work with you. And he's like, really? And you're all saying, oh my gosh, like the surgeon was like, really? Now, this might not be easy with all surgeons, and some surgeons might just walk away. But Anna had moral courage. And he said, really? And she said, yeah. He goes, well, what can I do? And she's like, well, after the weekend, ask them how their weekends were, get to know them a little bit, you know, show a little bit of interest in their personal life. Small talk. He goes, okay, I can do that. The next time he was there, he specifically sought out Anna and asked how he was doing. And you know what? He was doing great. He took the constructive feedback. He wasn't defensive about it. He had some self-awareness and no issue since then. Now, I am not saying you can do this with every surgeon. I have had surgeons that I've tried to talk to that literally just have walked away from me. But again, you'll never know if you don't try. So B is not the wrong answer, but like I said, in a really mature environment, I think it's a great answer and you want to work towards that. Let's look at the next one. You are working day shift. When you walk past the nurses station, it's obvious that a couple of nurses are having a conversation about their coworker who was off that day. They are discussing all the things he had not completed the night before. What do? You really think John should know about this situation, so you decide to tell him the next time you work with him. B, you address the situation by saying, I don't feel it's right to talk about John when he's not here. Please stop and speak with him when he returns. Can I count on you to do that? And then C, you sit down with your 2 co-workers and discuss how you should make a list of these concerns and ask to meet with the manager. What do you think the answer is? Let's see, what are people saying here? I didn't go up far enough. A lot of people I missed here. Sorry about that. All right. Just refreshing one more time here. Let's see what we got. Okay. A lot of you said B, which is great. Now, B is the right answer. You address the situation by saying, I don't feel it's right to talk about John. But what normally happens? You're a kind person if you really think John should know and you want to tell him, and there's nothing wrong with that, but what does that create? It creates the drama triangle. John is the victim. The people that we're talking about him are the persecutors, and you become the rescuer. And that's not healthy communication. And then, of course, some people just sit down with, this is what we see a lot of. See, you sit down with your coworkers and you just join in. And you know why that is? It's because there's comfort in validation, right? If we don't care for a person or we don't like what they're doing, it's comforting to know that other people think that. But there's discomfort in confrontation. And so that's where this peer-to-peer accountability comes in. And what we know about accountability is that on poor performing teams, there is zero accountability. Makes sense, right? On mediocre teams, who's holds people accountable? The boss, right? But the boss isn't always around. The leader's not always around. On high performing teams, it is a common expectation that peers hold each other accountable in a respectful and constructive manner. We have been doing a lot of work with cell phone usage in the OR. Who isn't with cell phone usage? It's just a conundrum for sure. And I had surgeons actually complain to me about staff using it. And so we've been doing some work. And one day the clinical coordinator went into the OR and one of the staff nurses had her cell phone out. And Caitlin said to her, "Hey, Tanya, you need to put that away. It's our policy." And Tanya was okay with it. She said, "Oh, okay, I'm sorry." A couple hours later, Tanya came to talk to the nurse and said, "Listen, I'm really sorry. I had something with my kid." And Caitlin's like, "No, but we really have to work hard. It's our policy. It's not safe for our patients." About a week or two later, Caitlin, the clinical lead or clinical coordinator, walks into the OR and she witnesses Tanya telling another staff member, "Hey, listen, I know we haven't been doing a good job about this, but we really need to pay attention. No cell phone. We have to put our cell phones away." Peer-to-peer accountability. Because I remember times walking past someone saying, "Hey, put your cell phone away." And they'd say, "Well, Joe has his cell phone out." And I'm like, "Well, I didn't see Joe with his cell phone out." That's where peer-to-peer accountability comes in, and you can do it respectfully. And it takes time. It takes time. And the last scenario, you are a new nurse with 6 months of experience. After receiving a fresh post-op patient, you see the orders and restart the patient's PCA. About 15 minutes later, while the charge nurse is rounding, she approaches you at the nurse's station and tells you that you programmed the PCA incorrectly. She starts yelling at you in the middle of the unit and tells you that you are incompetent. Sound familiar? We talked about this a little bit before in my own experience. So what do? Explain to the charge nurse, "I had 2 back-to-back admissions and did not have time to ask someone to check my PCA." Ask a peer to take over for a couple minutes so that you can have some time to compose yourself. Or C, say to the charge nurse, "Are you aware that you are screaming at me in front of patients and families? Can we discuss this later in private?" What do you say? Yeah, she's right. Linda, I see a comment by Linda. She's so right. And what she says, "I think people do not want to be on the outside of the group, even if the group is causing damage." Isn't that the truth? But we have to work on that because you'll never have a healthy team. It's empowering. You're never going to get rid of negative people, but you need to empower the more positive people to speak up. So a lot of people put C. Say to the charge nurse, "Are you aware that you are screaming at me in front of patients and families? Can we discuss this later in private?" Right. You're naming the behavior and you're talking about it in private. Now, the other 2 answers, when you think about it, there's nothing wrong with them. Maybe you did have 2 back-to-back patients. That could be very factual. Or it would have been a luxury if you could have left for a couple minutes to compose yourself. But you know what? That doesn't address the behavior of that charge nurse. The other 2 answers are maybe factual, but you are ignoring the problem with the charge nurse and being disrespectful to you and yelling and screaming. So thank you all for your participation with those scenarios. So what happens when we confront? What might be the outcomes? A person doesn't realize that they have bad behavior. These are people that you can really work with. You point something out, Christy, like, rolling your eyes in a staff meeting and having sidebar conversations, that's not okay. And they make effort to change their behavior. They're not perfect. They don't do a 180, but they have self-awareness. Dr. Burke saying, hey, stop yelling and screaming in my office. Let's work on this. Self-awareness. Some people have deep-seated issues, and that may be beyond what you can do. That might require HR. And then these are the hardest people to deal with. They are not willing to take responsibility, and they have no self-awareness. And a study shows that, do you know that people that have self-awareness are 90% successful in their job and in their life, and that people that aren't self-aware are about 50% successful. I haven't talked a lot about self-awareness, but it's extremely important. So I've given you a couple tools, right? But what happens? What happens when you're still having these bad behaviors? What do you do next? I know people hate to hear this and they don't like to do it. And I really struggle with getting staff to do this. You need to document date, time, location, witnesses, and you have to align that behavior, that bad behavior, to patient safety. Let's go back to that first slide. 250,000 people die every year from preventable errors, 85% related to a lack of communication. So we need to align those to safety, quality, patient satisfaction, and team communication, and take it up the chain of command. Well, what else can we do in terms of making a more positive work environment?
Look, I can be a sark. Now my whole house is great. I can do anything good. I like my school. I like anything. I like my dad. I like my cousins. I like my aunts. I like my Allisons. I like my mom. I like my sisters. I like my dad. I like my hair. I like my haircuts. I like my pajamas. I like my stuff. I like my rooms. I like my whole house. My whole house is great. I can do anything good. Yeah. I can do anything good. Better than anyone. Better than anyone.
I've had so many people when they see this video say, oh my gosh, that little girl's going to crack her head on the porcelain. It's all about positivity, right? And it just takes one. This is an example from a unit that we worked with where a nursing assistant just decided she wanted to give kudos to her team, and she stuck this star on the locker of everyone, just recognizing them for their great teamwork. And then a week or two later, someone else on the team passed it forward about recognizing team members. This is a picture from the unit that I managed, that was the nurse manager for 11 years. This is what we call the tree of life. And what this tree was, is this was obviously, there's hearts on it, was Valentine's Day. We had two of them side by side. And so we would have a theme. This was Valentine's Day. Who are the people you love? Mother's Day, moms, or people that were your people that represented your mom. During Nurses Week, we had nurses bring in a picture of what they looked like when they graduated from school, and we had a contest. So different themes, Christmas and holiday pictures. And what was so cool about this was that it was in a hallway where everybody could see it, patients, families, physicians. And you know what it said? It said that as nurses, as staff, and this wasn't just for nurses, it was for everybody that worked in the unit, we're human too. We have people who love us and care for us. And we haven't even talked about in this presentation about how sometimes patients and families can treat us unkindly. But it's kind of a message, and it really sparked a lot of positive conversation. So it's really about spreading positivity. And you know, we have to work very hard at spreading positivity, because as human beings, our thoughts are wired to the negative. We think about 60,000 thoughts a day, and the majority of them are negative. So you have to fight for positivity. And what you need is a comprehensive approach. We need to equip our leaders, who then will empower their employees, and in the end strengthens our organization, improves our safety and our quality and our patient experience. Those are all important. We all strive for those, but when we think about it, it's the right thing to do. And of course, keeping those lines of communication open. I saw this recently, and I have to move my chat window here. I think it was on LinkedIn, and it was a hospital that was putting posters throughout their hospital. And it says, please take responsibility for the energy you bring into this building. Your words matter, your behaviors matter, our patients and our teams matter. Take a slow, deep breath and make sure your energy is in check before entering, especially during these times. I've done this presentation many times for different groups and different formats and geared to different people, but more than ever, this is pre-pandemic, and more than ever, we need to have more positive energy. And then be kind. We have these buttons. I wear mine all the time. I can't tell you how many times it's been a conversation piece. When I travel across the country, I have had school teachers, I have had engineers. The flight attendant on one of my flights asked me about it, and I told her about it. I actually gave it to her. A couple of weeks ago, I was at a girls' weekend, beach weekend, and on my way home, I was by myself. I stopped at a Starbucks, and there was a gentleman who had a Be Kind sweatshirt on. And I went up to talk to him, and his wife was a nurse. And I gave him a couple buttons, and he probably thought, who's this crazy person? But I said to him, if you have a Be Kind sweatshirt on, I bet you I can talk to you. So it's not enough just to say those words or wear a button. It's the whole package. And what we need to remember is this, pretty much in closing: the greatest antidote to cruelty is kindness. My father always tells me, my dad is 83 years old, and he always tells me, and since I was a young person, leave a place better than the way that you found it. And remember that every conversation you have should be to build the relationship, not tear it down. Ask yourself, what legacy do you want to leave in your organization, whether you're there 2 months, 10 years, or 40 years? Do you want tears or cheers when you leave? Or do you want people to say, don't let the door hit you in the behind on the way out? Because I'm sure some people have had that said about them. And the ingredients to teamwork are this: remember, drama thrives where relationships are weak. And remember to tell your teams, it's not you against me, it's us against the trials that we face as a team, as an organization, especially during times of this pandemic. And don't forget the importance of connection and inclusion. The two best things that you can do today, starting today, is assume noble intent and go to the source. By doing this, you plant the building blocks in developing an emotionally intelligent team, which in turn leads to a healthier work environment. In closing, I'd like to share with you something that my mother sent me. My mother's 83 years old, and she's on Facebook, but I'm not, which is kind of funny. The grandkids all laugh about it. And she sent me this, and I think it is so appropriate in closing about positive communication and building a healthy, nurturing work environment. Being rude is easy. It does not take any effort, and it is a sign of weakness and insecurity. Kindness shows great self-discipline and strong self-esteem. Being kind is not always easy when dealing with rude people. Kindness is a sign of a person who has done a lot of personal work and has come to a great self-understanding and wisdom. Choose to be kind over being right, and you'll be right every time, because kindness is a sign of strength. Thank you very much for the opportunity to present to the Virginia Nurses Association. I wish I could see all your faces in person. I'm used to seeing lots of happy, smiling faces, but I think we're making the most of it. It looks like we have 5 minutes. I'm very happy to answer any questions if you have any.
Diane, thank you so much for a fabulous presentation. We'll wait and see if anybody generates more questions. I had forgotten earlier that there is a lag in this as well.
They warned me, so it's, you know.
Yeah. I had forgotten. But until those questions pop up, I just want to say that it was just so helpful. The words of wisdom, the exercises, the strategies, the scenarios. Thank you for sharing the personal stories. The statistics are just staggering. Almost 50% of nurses admit to being bullied in the workplace.
I know.
Affects concentration, collaboration, retention, the bottom line cost to healthcare institutions, to patient satisfaction.
Exactly. I know.
And I think the sad thing is that we're seeing this throughout the country right now because of all the issues that we have.
Yes.
That there's a lot of incivility happening. And I think we can all learn some great lessons for this that don't just apply to work.
Exactly. Yes. Yes.
Yeah. And I love the idea of moral courage
Mm-hmm.
and just saying, does it feel right in my gut? So thank you so much. And are there some questions?
I just have some comments. Oh, where did you get the Be Kind buttons? That's very easy. So after this, Chrissy Burke is our VP of Patient Services at the Healthy Workforce Institute. I believe she has a virtual, and let me go to the last slide because I always forget this. The healthyworkforceinstitute.com, that's our website. Renee, who's the CEO, has tons of resources. There's things you can buy, but there's a lot of free things. There's newsletters you can join, but you can get Be Kind buttons from that website for the person that asked me. I have like 500 of them in my office and I give them out wherever I go. So that was a question. And many of these tools that I talked about are also on that website. And Renee, she has if people may already follow her, there's coffee and conversations, there's YouTube videos. So there's lots of things that you don't have to pay for. Of course, there's lots of resources and things like that. But I think if you go on there, you'll find a lot of these tools that you can access. And then the Be Kind buttons and things like that, and note cards and things like that. So. And I don't think I see some comments, but I don't see any questions. So I am going to hop on the exhibit hall with Chrissy in case anybody thinks of anything.
Oh, that's fabulous. Well, thank you again. I know we all appreciated everything that you had to share. That was really wonderful.
Thank you.
I do let everyone know that
the first time I did this and that, once I do something once, I feel in terms of like looking at my YouTube and this and that. So
yeah, it's a little bit of juggling until you get used to it.
It definitely is, but it's the reality, right? We have to learn to do that. So.
It is. We're all going to be tech pros by the time this is done.
Yes. Yeah. Thank you so much, Janet.
Thank you.
Bye, everyone. Thank you.
And I did want to let everyone know that we will now have a 1-hour break sponsored by Virginia Relay. So be sure to visit our exhibitors and their virtual exhibit halls by following the link on our conference landing page. You'll have 2 chances to win a $100 Amazon gift card by participating in our virtual exhibit hall scavenger hunt. And we've tried to make it really fun for you. Just a reminder, all the information you need for today can be found in your conference email or at tinyurl.com/2020 VNAFC. And if you haven't already done so, we ask that you sign our VNA Civility Pledge at www.tinyurl.com/VNA Civility Pledge. And boy, we'd love to see a significant percent of everyone participating today having signed off on that by the end of our conference. Also, don't forget to view our on-demand concurrent podium sessions and come prepared with questions to our Thursday happy hour chat. But before you go, please enjoy this video from the exhibit hall sponsor, Virginia Relay, and we'll reconvene at 3:45. Thank you.
Hi everyone, my name is Eric Alviar and I am the Outreach Coordinator for Virginia Relay. I'm excited to share with you on how Virginia Relay can improve the lives of others that may benefit from our services. Virginia Relay is a free public service which enables individuals who are deaf, hard of hearing, deaf-blind, or may have difficulty speaking to communicate over the telephone. As local Virginians, you can support individuals and families with resources to connect on personal and social levels. By learning more about relay services in Virginia, you have an opportunity to provide Virginia Relay as a resource to family members and friends. If you'd like more information, We've linked several brochures for you to download, or you can connect with me through email during the conference. Enjoy the conference, and I hope to connect with you soon.
Welcome back, everyone. I'm Kathy Cox, VNA's Commissioner on Nursing Education. Before I introduce our next speakers, please pull up the chat box and share with us one thing you learned from our keynote presentation, Cultivating a Healthy Workforce by Addressing Disruptive Behaviors. If you can just put some things in the chat box. One thing that you learned earlier. Speak it. Thank you, Vivian. Any other thoughts? I know I learned assume noble intent and go to the source. That leads for building blocks for a healthy team. Thank you, Melissa. Name the behaviors. Speak out that there are tools available to use, that things can change. Incivility versus bullying. I think they get mixed up. I agree. I thought that our speaker did a great job clarifying that. The wisdom of wolves. Nothing new, but Diane says nothing new, but be kind and speak up. Joanne, I learned more scripting that will help with open discussion. Speak with positivity. Trust builds clear. Kind, unclear equals unkind, right? Incivility is seen more than bullying, and it's addressed by addressing your culture. Jennifer says, speak up, practice your script. Robin talks about the importance of self-awareness. Lucy, additional strategies for managing incivility and building effective teams. Allison, I learned skills and techniques to speak out properly. Name the behavior, and then the difference between bullying and incivility. So thank you so much for sharing that in the chat box. So I agree. I think it's been a great start to our conference so far. Now I'm happy to introduce our next session. The Virginia Nurses Association Commission on Workforce Issues has convened an incivility work group intended to gather data, conduct research, and identify solutions to help address incivility issues in Virginia. The presenters for this session will share the specific work of their team and then facilitate discussion with participants to help further the work to end incivility and bullying in Virginia. Please join me in welcoming the VNA Incivility Work Group.
Good afternoon, everyone. I'm very pleased to be part of VNA's fall conference talking about this particular subject. I've been a nurse for over 40 years, and I recall my initial experience as a new nurse in a new town in a unit that I had never seen. What I can tell you from reflection on that experience is that I was actually the recipient of lateral incivility and bullying during my first work experience. So I never put those words to it back 40 years ago, but it's good to see the work that has been developed over time by ANA and now VNA focusing on this particular topic. Our work group got together in 2018, and the purpose of our work group was to explore lateral incivility and bullying among Virginia's professional nurses. I was not alone in this work at all. I was joined by Debbie Kyle, who I believe is the speaker during the conference, Ronette Langhorn, and Anita Scarbeck. We worked together for the last year and a half or so, exploring this issue among Virginia's nurses. As you have probably learned already today, this is an umbrella term for workplace violence. And that term of workplace and violence not only includes physical harm, but it includes these concepts of lateral incivility and bullying. And what we need to know as nurses is how to name these behaviors as deviant, understand the impact of these kind of behaviors on nursing and the nursing profession, and really to truly work to eliminate these behaviors in our workplace. We are very aware that there are toolkits of strategies that foster a healthy work environment. And so we want to be a part of that solution. What differentiates incivility from bullying? It's really not just semantics. As we explored these definitions, what we learned is that low intensity deviant behavior had an ambiguous intent to harm. It included being rude or discourteous or displaying a lack of regard for others. Those behaviors would be things like gossiping or spreading rumors or refusing to assist a coworker. And that can be further differentiated into vertical incivility, where someone in authority is demonstrating those behaviors, or in the case of our work group, lateral incivility, where it occurs between individuals and groups. So that's the definition that we were working with as we developed our survey. Now, to differentiate incivility from bullying, what you most likely have learned already today is that bullying is a repeated, unwanted, harmful set of actions intended to humiliate, offend, undermine, degrade, and cause distress. These behaviors include hostile remarks, verbal attacks, threats, taunts, intimidation, and the withholding of information. So there's clearly a difference between the two. Incivility, you don't really know that somebody wants to harm you or hurt you, versus bullying where it truly is their intent to harm you. So I'm wondering if anyone who is listening could share an experience of lateral incivility that they have experienced personally, and then how they dealt with it. Of course, we wouldn't want you to say names of people or of places, but I'd like to hear if anybody would be willing to share an example.
Feel free to use the chat box if there are any examples you would like to share.
Another question is, you might be able to share an example of lateral incivility that you witnessed, and might be able to also share how it was dealt with in your workplace.
So Marcia shares that we had a group of nurses that would go for breakfast and always leave certain nurses out.
That's a prime example of lateral incivility, where there's hurt. That is the end result of that. Could she also share how that person dealt with it? Or she, as the observer, how did she deal with that?
So she comments, not just leaving out, speaking about it in front of the other nurses. And then we have some other folks chiming in now. Amy says, moving of another nurse's personal items in a shared office space. Jennifer shares, I have a coworker that has on several occasions laughed as she walks by me in the hallway and has actually put me down in front of a new nurse on our unit. I've been trying to figure out a way to bring it up professionally.
Well, those are really good examples of lateral incivility that verges on bullying. I think the first step is to speak out and speak directly to the person that is demonstrating those behaviors to see if they understand the impact of what they're doing.
And Marcia responded that she thinks this is the one that got left behind. I think the nurses just got used to it, but did complain behind the scenes. Julie talked about how nurses would agree to participate in a check sheet and then trash talk it behind one's back.
I think one of the first comments that was made when folks were saying what they learned from the morning sessions is that you must speak out and share not only that is hurtful behavior, but that it results in poor teamwork. Thank you for those examples, because those are very clear examples of nurses intending or not truly intending to harm another, but those were examples that verged on actual bullying, particularly because they were repeated. So what is the impact of nurse-to-nurse incivility? We did some work in the work group of examining the literature, and what we found is that when nurses are incivil to one another, it's truly harmful to patients because it takes our focus off what we're trying to do for patients. It increases our medical errors, it decreases the quality of our care, and therefore results in negative patient outcomes. Another impact of nurse-to-nurse incivility is that it affects our performance, it affects our mental health, and it really has an impact on whether we want to remain within our organization or within the profession of nursing. And lastly, it's quite costly to organizations because they end up having to recruit new nurses, and we know the cost of orienting a new nurse climbs and climbs. So it is costly not only to us personally, but to our organizations as well. So the aim of our lateral violence in nursing survey that we conducted was to really get a perspective on what the current state of lateral incivility among Virginia's nurses was. We conducted it in November of 2018, and the results were to be used to inform VNA's next steps in programming and trying to understand how we can eradicate this behavior from nursing. Our survey was returned by 326 professional nurses. That's less than 1% of Virginia's nurses. It's not unusual when you conduct surveys to get low turnouts. As you well know, we all get multiple surveys probably within the week, that there's only so many of those that we're willing to participate in. The folks who responded, 73% of them worked in hospital settings, 59% worked on the front lines, 52% have been in practice for 6 to 20 years. So this was not a naive group of folks that were responding. 47% had more than 21 years of experience in nursing. When we categorized the results, we tried to look at whether there was a difference in the different generations to lateral incivility. And what we found is that 31% of our respondents were baby boomers, 31% were Generation Xers, and 37% were millennials. So I believe that we got a good response from across the age groups. What the root cause of lateral incivility that was identified by the respondents was that the vast majority, 81%, were treated with respect by their coworkers, and less than 20% attributed job stress and tension to lateral incivility or violence. But when it did occur, they said 41% of those indicated that those behaviors were either serious or somewhat serious as a professional issue. So I think what that tells us is that incivility and bullying do exist within our workplace, that most of us feel like we are respected by our coworkers, but that job stress can be a precipitator of this lateral incivility and perhaps bullying behaviors as well. So what would you consider be things that facilitate a civil behavioral environment in your workplace?
While we're waiting for folks to join, to put their comments in the chat box, I would hope that there wouldn't be, well, it's hard now that we're virtually, but when we be in person at work, that there aren't little groups that are talking behind your back, and that things would be mentioned face to face. I see Amy talks about sharing a common goal that's clearly identified. For example, increasing patient satisfaction scores. Jennifer says teamwork. Respect and professionalism, investing in the team. Julie says willing to help colleagues. Jean shares top-down respect for each other's strengths and weaknesses. Diane says staff meetings with an open forum, no set agenda. Patricia shares acknowledging others. Hello, good morning. Lucy says modeling, good role modeling. Thank you for sharing those in the chat box.
I would add that I really think the manager of the units or the departments have a key role in establishing what is considered civil and professional behavior on their units. And I really wonder whether this is where we need to provide tools for those who are in management positions. I'm concerned that we have folks that are really good nurses that can get promoted to management positions, but don't really have the skill set to handle these kinds of deviant behaviors. So I do think that we should explore that possibility of providing a toolkit for those who take on management responsibilities. Let's move on. The other finding that we had is that 53% of our respondents did not consider coworker behavior such as losing patience or aggressive directing as either incivil or bullying. And 70% indicated they had not personally observed incivility or bullying towards another coworker. I find that incredibly interesting. I wonder really if we are so busy in our day-to-day experience that we often miss these times when folks are not really being kind to one another or respectful. Of those who have been the recipient of incivil behavior or bullying, 41% viewed themselves as powerless. 65% were unwilling to stand up to the coworker, and 49% felt unsupported by others in the workplace. So I think what this demonstrated for our work group is that once you're the recipient, you're in a very delicate position. So it behooves us to take on a set of strategies that will help us not feel powerless, give us an understanding of the way to stand up for ourselves and our coworkers so that they can feel supported when they're feeling like they are being bullied. Some other findings that we have found from our survey was 42% felt that they would not be safe from retaliation. However, they would report those behaviors. I think that's pretty incredible piece of data, that you wouldn't feel safe from retaliation if you reported those behaviors. 19% felt they would not be safe from retaliation and would not report those behaviors. 61% indicated they never used behaviors that would be considered lateral violence or incivility towards a coworker. 5% indicated they often or sometimes demonstrated bullying or uncivil behavior towards a coworker. So a small majority of us are recognizing that sometimes we are uncivil towards our coworkers. 58% indicated there was incivility and bullying among members of an interdisciplinary team. I participate in interprofessional rounds, and sometimes I see that occur during those rounds. The last point being 27% indicated they left a position because of lateral violence. So there are indeed consequences to this. Interestingly, the perceived causes of incivility and bullying was really stress, inadequate staff, and inadequate resources to handle the workload. So some of the work that VNA is doing around staffing that is supported by the ANA's model, I think is really a smart move in trying to relieve stress and get at that one of the perceived causes of incivility and bullying. One of the strategies that was described and sought input regarding was workplace education. As a part of Joint Commission, it was important for lateral incivility and bullying to be addressed. It's part of one of those essential components of getting reaccredited. 61% believed that something could be done to help solve this in the workplace. 60% reported that they actually received education on techniques. And 28% indicated they thought it was very effective, but over half indicated it was just somewhat effective. So having a code of ethics or a code of conduct at work can only go so far, as I think the message that we got related to that. There are tools already available. ANA has their position statement, which is quite clear about what is considered incivility, bullying, and then workplace violence. ANA also has a book out called Bullying in the Workplace, trying to reverse that culture. And there are some other very poignant books, one by Dr. Renee Thompson called Enough, Eradicate Bullying and Incivility in Healthcare. So we want to know how VNA can help you. We in our work group were putting out ideas, and we really thought we needed to hear more from folks who are practicing at the bedside. Should we have a monitored blog where you can tell your story? Sometimes putting words to what you've experienced may be helpful, but doing that so that you don't put your own person or your organization at risk for litigation is where we struggled as a work group. Secondly, we were thinking about whether we needed to really develop workshops that allow role-playing and storytelling so that individual nurses could develop personal strategies they felt they truly could use day in and day out in their workplace. Another idea we had was, should we have forums for healthcare leaders to become not only aware of the issue, but its impact on the outcomes of their organization so that they would support a change in the culture or environment. And lastly, we toyed with the idea of VNA functioning as a liaison to support the use of organizational processes that are already in place or community resources that are already in place. So we as a work group really would like to hear from you. Do any of those ideas resonate for you? Do you have a different idea that would help us move forward? Since we already have an ANA toolkit, we already have lots of information out there in article and book form. How can we help move this to the next step? I'd like to hear from you.
I see in the chat box, you mentioned the blog. So Catherine comments, the blog would help people name behaviors, which is important, as we just learned from the keynote. And we have another comment, sad, how we can be compassionate toward our patients if we're not compassionate to each other.
Quite true. So we have one person who thinks a blog that actually helps people name the behaviors would be helpful. Any other ideas from the group?
I don't see ideas coming up just yet, but I do see a thank you. And I a shout out saying hello to you, Linda.
Hello back.
That's from Jen Beth.
Hey, Jen.
So Joe says, I like the idea of the educational workshops where individuals can role play and get their own strategies.
Okay. We actually have a couple folks in the VNA world who really like teaching workshops about this. I think Debbie Kyle would be really open to creating a workshop because she did this for her doctoral work. But I think that whether we are young in nursing or we've been around for a long time, some of us learn to accept poor behavior just because that was the culture we were educated in.
I agree, Linda. We've got a couple more comments. Laura says additional training resources for staff to learn emotional intelligence, something to send the bully to for education. Catherine says we did role play at our hospital, but many did not take it seriously. Amy comments mediated sessions with a practice group that is struggling with incivility. Chante says use my moral courage, because that's what our first presenter talked about. Jean says specific training for nurse managers and adopting the expectation that incivility is not tolerated. And Dorothy comments new leaders could benefit from mentoring or workshops to learn how to support their team, especially new graduates. Julie, now people are on this, Linda. Julie talks about create supports for leaders so that they don't fall into incivility themselves. It's more than education. I knew leaders who were unsupported and fell into negative behaviors.
So Catherine, are we going to be able to keep all those ideas?
Yes, we'll be able to get those through the recorded.
Okay, because I don't want to lose any of those ideas. I really think that this is exactly what our work group wanted to learn. Where do we take this next? And a blog and workshops and managers and leaders knowing how to respond, how to create the right kind of environment. Those are the things I've heard so far, but I don't want to lose any of those ideas that are in the chat box.
We've got it. We're saving.
Cool. How'd I do on time?
You're doing great. We're down to about 25 seconds.
Okay. All right, everyone. I really appreciate your participation in this, and I very much thank you for your ideas on how to move this work forward. Thank you.
Thank you so much, Linda and colleagues, for the work you and your team are doing. As an academician, I appreciate the work group investigating the literature and your sharing of the lateral incivility among Virginia nurses survey that you deployed in 2018. It's encouraging to hear that 81% were treated with respect by coworkers. However, when it did occur, it was categorized as serious. Managers do have a role with this and correctly need the tools, skill sets to handle deviant behaviors. Feeling powerless and unsupported when being bullied, that is unacceptable. You mentioned a perceived cause is stress, so it's great that the VNA is targeting this as well. So again, thank you very much. And thank you to our audience for giving the work group some great suggestions. At this time, I would like to welcome leaders representing the Virginia Nurses Associations and Virginia Hospital and Healthcare Association's Workplace Violence Work Group. This work group was formed as a result of legislation passed on workplace violence and the recommendation of the Virginia Department of Health. This work group is focused on promoting healthcare workplace violence prevention programs across the Commonwealth. The presenters for this session will share the specific work of their team and then facilitate discussion with participants to help further efforts to end workplace violence in Virginia. Our first presenter, Kelly Cannon, serves as the Senior Director of the Virginia Hospital and Healthcare Associations Foundation. She directs VHHA's advocacy efforts on healthcare policy issues at the state level and manages the Political Action Committee, HOSPAC. Kelly is a College of William and Mary graduate. Go Tribe, Kelly. A 2007 Fellow of the Sorensen Institute for Political Leadership at the University of Virginia, and holds a certificate in fund development from the University of Richmond. Kelly is active in the Junior League of Richmond. Our second presenter, my VNA colleague, Melissa Early, earned her National Registry certification as a paramedic at the Medical College of Virginia and her Bachelor of Science in Nursing from Virginia Commonwealth University. She is registered with the Board of Counseling as a qualified mental health professional. Melissa is also a National Healthcare Disaster Professional, board certified by ANCC, and a member of the Virginia Department of Behavioral Health and Developmental Science Services Disaster Behavioral Health Response Team. She also actively volunteers with the Medical Reserve Corps and serves on the board of directors of the Virginia Nurses Association. Please join me in welcoming Kelly and Melissa.
Thanks, Kathy. I want to thanks everybody for letting us be here today and talk about a very important topic of workplace violence. I don't like that we have to talk about this topic, and unfortunately it is something that is very prevalent. The VNA and the VHHA have been partnering on this for many years, and I'll let Kelly give her introduction as well.
Sure. Thank you, Melissa. Good afternoon. As Kathy mentioned, my name is Kelly Cannon, and I've had the pleasure of meeting many of you at your conferences in person over the years. This is my favorite event to attend, so I'm disappointed to not be there with you, but appreciate the invitation to join you in your homes and your living rooms and your workplaces today. VHHA has been very proud to partner with VNA on a number of pieces of legislation over the years, and most particularly, we're proud of the work we've done together on workplace violence. So Melissa and I will talk through two of the major pieces of legislation that we've addressed in the last 4 years or so, and then welcome your comments and opportunities to do more together.
Okay. The National Institute for Occupational Safety and Health defines workplace violence as a violent acts including physical assaults, threats of assaults directed towards a person at work or on duty. That is just one definition of workplace violence. There are many others that have been used by the Joint Commission and other entities. And we'll talk more about those a little bit later. And Kelly, I believe you wanted to expand on this.
That sounds great. I've got some, if we go to the next slide.
Okay.
So I am not a clinical staff member. I don't have to tell you all that violence in the healthcare workplace is a serious problem. I hated to hear the first presentation about incivility, and even more so, we hate to hear about physical violence happening. VHHA, as you all know, likely represents, so my members are all the hospitals and health systems, and we take very seriously our responsibility towards our workforce. It's a top priority for our board, and it's honestly, personally, a very top priority to me. What we found is that healthcare providers, particularly nurses, and particularly folks who work in the emergency department, are subject to various forms of violence, including physical attacks and intimidation and verbal threats. And those threats can extend beyond the walls of the hospital. Even we've heard several really disturbing cases of threats to nurses' families. And in this golden age of technology, everybody's a little more trackable. So those can be really, really terrifying in some cases. Hospital workers are 5 times more likely to require time off from work due to injuries. And the OSHA report that 75% of nearly 25,000 assaults reported occur in healthcare settings is certainly cause for alarm. I'm happy to tell you that when we've brought these pieces of legislation to the General Assembly each year, we've found very receptive audience because the legislators were very committed. They're have a strong belief. I think you all probably know that nurses poll is probably some of the top professions in the state, and everyone cares about protecting you. So that's been our driving force over the last couple of years. Melissa?
I testified for the legislation that was passed, and this is actually the photo that I used for both pieces. It didn't have quite as much detail as far as the before and after, but this was my journey with my own incidents of workplace violence. The top row of photos shows pre-injury. I surfed a lot. I was able to volunteer with the rescue squad. If you can notice that there was well-defined, well, I won't say well-defined musculature in my trapezius muscles. After the injury that I suffered, I was working, and I was engaged in breaking up a altercation between several patients, and I was literally flipped in the air, watching it back on video, higher than my actual height, and landed. And when I came to my feet, the patient tackled me. And as far as staff members, nobody did anything. We were following our protocols. We were doing everything exactly the way we were supposed to do it, and it still happened. In the heat of the moment, I didn't even realize that I was injured, because my focus was on keeping the patient safe, making sure the patient was safe. And after things were over, I just I grabbed my left arm, and I realized that it was kind of just hanging there, and I instinctively just pulled it, and I felt it pop back in. So my shoulder was completely dislocated. I've had 2 surgeries, and if you notice in the second row, that's a mirror image. It looks like it's my right shoulder, but it's actually my left. I have scapular winging, and I still have that. So even though the injury was in 2015, I still, I can't sit comfortably. And so it's 5 years later, something that I still deal with every day. The first surgery I had was an open repair, and that shoulder surgery is not for sissies. The recovery from that was probably a year long as far as coming back from the surgery. And then I had to have a second surgery because I had an encapsulation. So it was quite an ordeal, and it's something that I am still dealing with 5 years later. And when I hear about others who have had a workplace violence incident, I consider mine mild compared to others, and at the same time, it's something that will stay with me for the rest of my life. And it's something that was preventable, as you'll hear. later when we talk about the second piece of legislation. Whoops. So I kind of talked about how I had been involved in workplace violence. In 2017, VNA and the VHHA worked together on legislation to address battery of a healthcare provider. At that time, the only group that was protected were people who were physically working in the confines of the emergency department of a hospital. Even if you were working in the ED, if you stepped outside of the emergency department, the confines of the emergency department, you lost protection. And so if you were transporting someone to the floor and something happened, even if you were an emergency department nurse, you were no longer protected under the current law at that time. And so in 2017, there was legislation introduced to expand the coverage to include all healthcare workers in the performance of their duties, and to also add a mandatory minimum penalty or sentencing to that. And I kind of got involved by chance. I was still out from my surgery, and I had answered one of the texts that was sent out to call for nurse ambassadors because I had some time on my hands. And I went to the General Assembly, and it just so happens that was the bill, one of the bills that VNA was involved in, and they were looking for somebody that had experienced workplace violence that would be good to kind of be the voice and the face. And so I was there, and I testified for the bill, and it was interesting. It was in front of the courts of justice, the Senate Committee for Courts of Justice, and several things came up. Usually when you testify, it's maybe I'm here representing so-and-so, and we support that. I was up there for probably, it felt like days, but it was probably about 10 minutes or so. And they were asking me a lot of questions, about, well, you're a nurse, didn't you sign up for this? Don't you expect to encounter this? And I mean, I answered honestly, and I said, we don't get self-defense in nursing school. We're not taught that. And what if the person is having a bad day? What if they're suffering from some sort of mental illness? And, what if they're in pain? And I said, there's a small percentage of people that, if they have a mental health diagnosis, that they don't know right from wrong. I was, if they're having a bad day, we all learn in kindergarten to keep our hands to ourselves. If you're in pain, punching the person that's going to bring you your medication is not the way to get your needs met. It was questions like that. And it was, I think they were just trying to understand, is this really a problem? And by the end of the testimony, they realized that, yes, it definitely is a problem, and it happens every single day. And I think the thing that really kind of sent it home was when they asked about, how often it happened. And when I said, there are hospitals here in the Central Virginia that go on diversion, not because, beds are, of course, this wasn't pandemic time, but not because, the beds are full, but because there aren't enough staff, because nurses are leaving the profession because they don't feel safe. And I think that kind of really drove it home, because people that I graduated with, I knew were worried that they weren't safe. So that was a very eye-opening experience for me to see that process, as well as I think it was very clear to the legislators that you know, this was a big problem.
I want to, so by definition, battery includes physical assaults that result in serious physical harm, as Melissa described. The next slide. I want to really reiterate, I am a paid lobbyist for the Hospital Association, which means I work for all of you, anyone who works for a health system. Those moments in a General Assembly hearing, they happen 1 or 2 times a session where someone, a brave individual like Melissa, steps up and is willing to share their personal experience. And folks do that every day, and we see people line up outside the door, but every once in a while they grasp that individual really grasps the attention of legislators, and that's what happened with Melissa. It was powerful. She commanded the room bravely, and I share that only to say that when you see those calls come out from VNA, or hopefully if you sign up for VHHA's grassroots alerts as well, consider participating. Consider taking a day to go to a lobby day when we have those again, in person or virtually, or reaching out to your legislator if you have a personal story to share, because it can make all the difference. The questions that she shared that were asked, they were genuine questions. Isn't that part of your job? It sounds devastating to all of us to think that, but I think these folks had never put themselves in a nurse's shoes before. They hadn't considered the moment. And she was able to take them to that place and help them see it through a provider's eyes, and we were able to pass the legislation. So I've always got to put in a pitch for grassroots engagement, and also a huge amount of respect to my friend and colleague Melissa for what she did there. So this is this is what the code language that came out of it. So expanding that battery language beyond the emergency department, but into throughout the hospital, or in an emergency clinic. What's the next slide?
Okay.
So those results are that we got to find out in 2019, we took a look back. So using that new code language, there were 63 convictions in the next 2 years of assault and battery of an emergency healthcare provider. That's a huge step in the right direction. However, none of us would be surprised to know that only 30% of nurses and 26% of emergency physicians actually report incidences of violence. You all face clear and present danger each day and have every reason to take threats seriously, but for various reasons, these assaults largely go unreported. And that takes us to the next piece of legislation that we pursued 2 years later, the follow-up. Go ahead, Melissa.
In between the pieces of legislation, the Joint Commission in 2018 introduced Sentinel Event 59, and it added verbal violence to the definition. Threats, verbal abuse, hostility, harassment, bullying, among other acts, which could cause significant physical and psychological trauma and stress in the absence of physical injury. And you will all be getting a copy of these slides, but this is a link that you can click to that Sentinel event. And actually, I'm not going to open it, but you can open it, and it's a link to the Sentinel event. And one of the things that is of note, it for magnet facilities, you know, something that is a Sentinel event, you have to have the things in place that they suggest, because you know it's a suggestion from the Joint Commission, but if you want to maintain your magnet status, there are certain things that you must put in place. The training talking about, verbal de-escalation. And you hear that a lot, verbal de-escalation, or do you want to de-escalate someone who is verbalizing, or do you want, what that is you using, a set of tools to talk someone down from escalating from just threatening, and I say just, but threatening into it escalating into physical violence, because that often happens once somebody has, their I call it their temperature rising. If they have started at the level of threatening and the desired response isn't gained, then it's likely that their temperature is going to continue to rise, and then the incident will escalate into a physical violence. And especially when in a situation where someone is a patient, or maybe they have a loved one who is in the hospital, and at that point they don't have the control. And when someone feels like they don't have a sense of control over their environment or their situation, that's the time when people will sometimes impulsively act on their anger and strike out with physical violence. So one of the things in this Sentinel event that is so important is it talks about training all staff in verbal de-escalation techniques. How do you bring someone down from that level where they're, just yelling at you, throwing threats, that kind of thing. And also, if there is an incident where someone is attacked, what do you do afterwards to support your staff and give them counseling either immediately after the event or long term? And that's very important, because working and taking care of people in general takes a lot out of you, but knowing that you're doing that in a safe place, it's a must. So that's one very important piece of that.
So the 2017 legislation criminalized battery, which was important, but we wanted to take a step further. And with that Joint Commission Sentinel event kind of under our arms, we wanted to take a step towards prevention. So as Melissa talked about, we wanted to get at that de-escalation moment and try to prevent physical harm from happening. So we put the band back together, so to speak, bringing VNA and VHHA's advocacy teams back together to work on legislation addressing verbal threats towards a healthcare provider. Now, I can tell you this one was a harder sell. Legislators said, oh, people say things. They just say things sometimes. They don't mean it. And we said, and yet sometimes they do. And that's not acceptable. It's not acceptable that you would go to a workplace each day and expect to be treated with disrespect, and specifically to be suffer threats of death or bodily injury. So that's the language that we used. We actually looked into the code. We found a lot of different options of ways we could get at this. What we wanted to do was be able to have an intervention moment when verbal threats were issued, but before physical battery had occurred. So something that the legislature and the Courts of Justice Committee almost never does is add a new protected class, but they did that for healthcare providers. I'm really proud of that. We realized that there was this code section that addressed threats on school property. I think there was a general sense that teachers and school staff shouldn't be threatened in this manner, and we said that same protection needs to be extended to healthcare providers. So here's the code language that we ended up with. A person who orally makes a threat to kill or do bodily injury to a healthcare provider who is engaged in the performance of their duties in an emergency department or anywhere in a clinic or in a hospital is guilty of a class 1 misdemeanor. We did add that orange exception language. We think that's really important. One thing we wanted to stress was that our providers, especially our nurses, are judicious and thoughtful people. And if an individual is suffering from a behavioral health event or episode, and they are actually seeking care because of an emergency protection order, involuntary hospitalization, that is exception language. Specifically, one legislator who was a public defender pointed out that that happens a lot when someone is already under the protection of officers who are with the patient and can provide physical protection for the staff. But this makes a big difference. This took a big step. And once again, it was Melissa's personal story that the patient who ultimately harmed her had stated earlier in the day that they planned to do harm to the providers in the room. And she did not have any interventional means at that point to protect herself, but had to keep doing her job. At this point now, those kinds of statements would result in further investigation.
And the work continues. The Workplace Violence Group was formed as a recommendation of the Department of Health, that the Virginia Hospital and Healthcare Association and the Virginia Nurses Association have an ongoing work group to continually address workplace violence. And we have at this time, we have a toolkit available on the VNA website that's accessible to any members, and it's something that is fluid because things are ever changing. New ideas are coming up all the time. New best practices are always changing, and we want to recognize that this is hopefully a problem that will go away, but it's here right now, and it hasn't gone away. So we know that we need to keep at it. So yeah, we are.
At this time, we welcome questions. You can feel free to put them in the chat. I'm monitoring that. And you know, if you have thoughts about legislative suggestions for the future, or what I always like to say is tell us your problem and I'll try to figure out how we can find a legislative solution to it if it's possible. We like nothing more than to try to run something down and figure it out. And there are a lot of very willing legislators who would like to tackle this issue and ensure, and certainly I can tell you that respect and appreciation for healthcare workers has never been higher than right now because of the pandemic and because of all the important work that nurses are doing on the front lines serving our communities. So feel free to put something into the chat here. I'll also probably should have put it on here, and I think I can tell you, go to our virtual exhibit hall. I almost forgot. Jackie would be so disappointed in me. VHJ was proud to sponsor the conference, and if you go to our virtual exhibit hall, you'll see my contact information. You'll also see an opportunity to sign up for our hospital grassroots network. That's how we send out a monthly newsletter about the politics and policy of healthcare, thinking a lot about our workforce and also other issues addressing healthcare delivery in the Commonwealth. We'd love to have you be a part of that. We'll also send out action alerts, just like VNA does. Often we partner together on those during the General Assembly session, and would love to see responses from you all. I'm, again, disappointed to not see you in person to have these conversations, but please don't hesitate to reach out, and we'll look forward to working together again in the future. Melissa?
I'm just honored to be able to do this work and to be a part of the legislation and to work with you. And there were plenty of others on the work group over the past several years, and can't name them all, but just thank you to everybody.
So I would like to thank you all today for presenting, Kelly and Melissa. I mean, great job, and lots of comments I'm seeing in the chat box with regards to Melissa sharing your personal story. I know that that's difficult, reliving sometimes those events through your storytelling, but certainly it has been proven to be effective in helping all nurses across the state. And so once again, want to thank you all for the work that you're doing on behalf of all the nurses in the state of Virginia through the VHHA and the VNA. So thank you all so very much. A couple of comments. I see a couple of questions in the chat box. Has there been any conversations with the Board of Nursing regarding consequences should a nurse defend his or herself in the course of workplace violence? So that's interesting. And repercussions from facilities when nurses report, are there? And that's from Marcia. And then multiple thank yous for the great presentation that you all provided. So I would hope, as we begin to wrap up today, that all of you would agree that this has been a great first day. Again, a huge thank you to all of our presenters today. And thank you, Kathy Cox, for helping us out, and everyone that helped bring this conference together, because there were many, many people that had to get together and work on this, and we appreciate all the efforts of everyone. And we also would be, or I would be remiss in recognizing Janet Wall, our CEO, and the wonderful staff at the Virginia Nurses Association, because this has been a labor of love for them. And so we appreciate all that they do to help support our nurses. So this morning, many of you shared what you had hoped to gain from participating in this conference. You included things like strategies to support those experiencing bullying, tools to stop workplace bullying and prevent bullying at the start, creative ways to open dialogue concerning feelings of bullying, and ways to help nurses be respectful toward colleagues with views different than their own. I hope you would agree that on this first day, we were able to deliver, and we have more to come tomorrow. It's now time to announce the winner of the $100 Amazon gift card for our exhibitor scavenger hunt. Without further ado, the winner is Joan Deal. Congratulations. If you didn't win today, there's still a chance to win another $100 gift card for the exhibitor scavenger hunt tomorrow. And we'll also be giving away another gift card out for our Exhibitor Interaction Award. So be sure to visit our virtual exhibit hall. Don't forget to view our on-demand current podium sessions and come prepared with questions to our Thursday happy hour chat. We'll see you all tomorrow at 9 a.m. for day 2 of the Virginia Nursing Association Fall Conference, ending civility, bullying, and workplace violence. Have a great evening, everyone. See you tomorrow and stay safe.